I think I may just mention that if we go beyond 12 o'clock, I'll leave because
No, no,
I am.
aim is not to go beyond 12 o'clock.
It may not go. We have, yeah.
Yeah.
I mean, I'm just saying.
Yes.
Suddenly you will find me disappear.
Right. So slides are visible. Slides are visible.
Yes, 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 yes.
Title
Right.
slide is visible. Title slide is visible.
Right. So I'll start with the first topic today, infectious myelopathies. And I think we can discuss the points in between as well, or at the end, whichever way we choose. I think in between also may be a good idea, because that way the material is up for about 20 minutes. So we could discuss in between. So the topic is infectious myelopathies, the infections of the spinal cord. And to introduce the subject, spinal cord may actually be directly invaded by the infection, and there may be a secondary inflammation as a consequence of the invasion. The structures may be compressed, or fourthly, there may be a spinal cord dysfunction related to immune mechanisms triggered by systemic infection. So these are the four ways in which the continuum tells us that the spinal cord gets affected. Spinal cord dysfunction related to these four mechanisms. And maybe if I can start off a little bit with practical difficulties that I have had with this. Our bacteriology in the city of Bombay is, I would say, reasonably weak. And therefore, when you see a myelopathy, for the clinician, there is always a question. Are we looking at a direct infection of the spinal cord with something? Or are we looking at an immune myelopathy? Now, that is something that I, as a clinician, have always found it very difficult to separate in the local scenario. And I also appreciate that these two are not completely separate, but they are intermingling. I mean, finally, the bacterium or the virus or whatever, when we say direct invasion, the mode of damage is inflammation. So both the things are interactive. Our bacteriology
Would you
is
like
improving.
to give an example to illustrate your point?
Yes. I think when we sort of say that there is a tuberculosis of the spinal cord, and the tuberculosis has affected the vertebrae and the discs and the meninges and the substance of the spinal cord, a kind of myeloradiculopathy. Like in the cerebral tubercular meningitis, there is a component that directly the bacterium does, and then there is a larger component that the immune system does and keeps doing. So the combination of what the virus or bacterium directly does and what the immune system then does is one of the issues. And if we take the fourth point on this slide, the spinal cord dysfunction related to immune mechanisms triggered by systemic infection, I don't even know whether this should be put in this chapter or whether this should be put in immune myelopathies. The example given is mycoplasma. Mycoplasma is in the lungs, but it elicits a response in the spinal cord in some patients, producing a myelopathy. Now, that's really remote. So those are some of the issues that conceptually exist between the direct and the indirect ways in which spinal cord is affected. And maybe for a minute, we could talk about this before we go on. So if I could request Dr. Kartarak, Dr. Shirsad, Dr. Lal Kaka to make their comments about what they have seen in all these years, because I have always found this as a question. Of course, bacteriology is now improving. And therefore, you may get evidence of some bugs. Now, the evidence may also be just by an indirect assertion that the bug was there, like a DNA or an RNA or the viral genome detected. So what does it mean in the context of the spinal cord dysfunction? Please.
I'd like to kick off by saying the most classical example of infectious myelopathy in our situation is either viral transverse myelitis, where we have never been able to prove the virus.
Exactly.
Okay, except in cases like poliomyelitis,
Right.
or polioclastic diseases.
Or when there is a herpes rash staring
Yeah,
at you.
something like that.
Yeah.
You have and then it's a vasculitic involvement of the spinal cord when you take herpes or
Yes.
herpes zoster viruses, zoster varicella viruses.
Yes.
The second commonmost condition is, of course, tuberculous spinal meningitis. But I think there the spinal cord is affected secondary
Compression.
to the inflammation of the meninges.
Yes.
There are several mechanisms.
Yes.
You can say compression, you can say vascular involvement,
Vascular.
so many involvements.
Correct.
Primary tuberculous myelitis is a rather rarity,
Absolutely. Yeah.
although we put it down. So I think direct invasion, okay, is very relevant in viruses, where because we don't find anything else, we say viral transverse myelitis.
Correct.
And invariably we treat it with steroids and the patient partially or significantly improves.
Yes.
So we really do not know whether it was a viral transverse myelitis or it was secondary inflammation to some process
Exactly.
which we don't know about.
Yes.
Now, compression is fairly easy.
Yes.
Compression is fairly easy. And the compression can be intrinsic. Rarely we get things like a tuberculoma within the spinal cord. Or it is usually extrinsic, where you have a pot spine and compression of the, or you have an epidural abscess or things like that, in which there's obviously going to be an inflammatory or a secondary infectious process affecting the spinal cord itself.
Yeah.
Now, spinal cord dysfunction related to immune mechanism triggered by systemic infections. I will be very frank and say I have very little knowledge of mycoplasma. I don't think those cases even come to us, because if it's in the lung, the respiratory physicians may be treating it.
Mm.
There may be brisk reflexes in the lower limbs, something like that. If at all a respiratory physician ever examines the nervous system cursorily.
But I think this will be the gray zone where to put them in
Yeah.
immune or infectious. Yeah.
In fact, I would put down one is direct invasion. Invasion of the covering meninges,
Surrounding structures.
secondary involvement of the spinal cord, which is the most common scenario as far as we are concerned.
Correct.
You know,
Correct.
compression is third, and I really don't know about the fourth.
The fourth one, yeah. Also, I think invasion and inflammation are together in each case. So it's a sort of consequence of the invasion. but sometimes it grows out of proportion.
And when you talk about immune mechanisms, what are the cells? Which are the cells that produce all these immune mechanisms? Is it the microglial?
Yeah. Some of
It
that
is
will
the
come, sir.
antibodies. It is the antibodies. What is it?
Correct. What elicits the inflammatory
See, as
response?
far as tuberculosis is concerned, there's a lot of literature of a tuberculoprotein. That the bacterium dies,
Correct.
liberates tuberculoprotein, which in itself produces a inflammatory reaction.
Correct. Same thing in leprosy.
Yeah.
Yeah.
And that is very relevant when you talk about strokes, because you don't find any tuberculous bacillus around the vessels. Yet there is evidence of inflammation in the vessels. And that is believed to be by tuberculoprotein. Believed.
Yes.
Nobody has ever, the inferences have been sort of
Conjecture.
indirect, because you haven't found the tubercle bacillus in the area. Yet you found inflammation, and therefore you conclude that the tuberculous bacillus has been killed and gone, and the tuberculoprotein is producing the reaction.
Yes. Right. Thank you, sir. Jimmy, Ashok, anything, or we move ahead? Yeah. Okay, we move ahead.
Yeah.
Probably.
We have two clear situations in our practice. One is people who come to us after day 4, day 6, and day 8, and something needs to be done for them. And second is people who come present to us right at the beginning. So I personally feel that what we can contribute more to the patient in the patient where they come in early to us. They may go early somewhere else where they've just done a lumbar puncture and given a broad spectrum course of broad spectrum antibiotics and then sent to us because they don't improve. So that I find very, very troublesome because it's already they received antibiotics. All the tests for bacteriological and identification or like biofire, whatever, you are not yet been done with them, and that's probably too late in the day to make a reasonable impact. All the cases that have done badly with us are the cases who come a little late in the game.
Right.
For us to make any meaningful contribution. It's very good to read all this. It makes sense if the patient comes to us de novo.
Correct.
If it comes to us after day 4, day 6, day 8, then it becomes
right.
very difficult.
Yeah, it's already gone. The time is gone. Yeah.
Can I just make one comment? This one case, very quickly. This guy, elderly man from Goa, I think he had a very, very bad infection of the chest. I think it was post-COVID or whatever. They couldn't manage him in Goa. And so they flew him down here and, a bronchoscopy was done. Thick pyogenic infection was found. I'm not sure what the organism was, if at all. They found the exact organism. And within 4 or 5 days, he responded very, very well to treatment. And they were, in fact, thinking of taking him home. And then suddenly, about 5 or 6 days after he was admitted, he suddenly had a urine retention and a 0 power in his lower limbs. And the MRI showed a long lesion, from the cervical right down to the end of the dorsal cord. So I'm just wondering whether, and we did everything. We really don't have an answer as to why this myelitis happened. But, I'm just wondering whether this fourth mechanism, Satish, could well be what has happened to this chap.
Yes. Yes.
Did the respiratory physician prove it was mycoplasma infection?
So I'm not sure. The bronchoscopy was done and, thick pus was seen. I'm not sure whether it was mycoplasma, and all sorts of exotic antibiotics were given. This, what is that, that thing which we give for atypical pneumonia, those sort of antibiotics were given. But
Yeah.
the fact is, he had a very, very bad pyogenic pneumonia, and that was soon followed.
Correct.
As that got better, this suddenly he just crashed in 24 hours.
Yeah. So this
But
looks
did he
similar.
improve? Jimmy,
But
did he
he's
improve with antibiotics?
so antibiotics, he improved from the chest almost completely, you know, but
Like spinal cord.
but nothing from the cord, sir. So then we started with a little bit of, the steroid under cover of the antibiotics, and then gave a little bit of IVIG. He's slightly better, but I mean, he's better by about 10%, you know. It was a complete transverse myelitis with zero power and complete loss of sensation.
Yeah.
Satish, from the chapter,
Yes.
the fourth mechanism, does it have a good prognosis or does it have
No,
a bad
they only touched upon it as a mechanism. Not too many details are there. But I would imagine that if the mechanism is immune, there is a scope for benefit.
Yeah.
Right. So we
Also,
go
it
on.
depends on when you catch the patient after the immune mechanism has worked.
Correct. Correct. Right. So we move on. Yeah. Right. So the chapter is very large and there are so many entities covered. So I will only take some of the parts that are relevant. I think when we approach a spinal cord dysfunction and we suspect infection, the factors like age, geography, seasonality, travel, social, occupational, and the immune status are extraordinarily important because they help us reduce our spectrum of differential diagnosis, as is the clinical feature like acute, subacute, and chronic. After having looked at these, we look at whether clinically we are dealing with an isolated myelitis or we are dealing with a myeloradiculitis, because the differential again can be narrowed down. When it's only myelitis, then we try and decide what is affected. Is it, example, anterior horn cell affected will be a polio or polio-like illness. Brunt on the lateral column will be HTLV1. So clinically, the first few factors are demography and immunity, then the course of the illness, then cord alone or cord plus root or cord plus whatever, and then structures affected within the spinal cord. That is the clinical approach to the problem. Now, radiology has become an inseparable part of the spinal cord dysfunctions. And in fact, when we are talking of diagnostic syndromes, we are really talking of clinico-radiologic correlations or clinico-radiologic syndrome. And there will be a talk on radiology about the specific features. This then follows, the microbiology follows, which is either guided by clinico-radiological features, or I think like everywhere else, we are going for blanket studies where everything is done that is possible, where you have primarily two ways. One is to look for the evidence of organism with standard microbiological techniques, and then looking for evidence that the microbe was there or is there by looking at the PCR and new generation sequencing using the DNA and the RNA sequencing in various ways. So the approach as usual is clinical, then clinico-radiological, then clinico-radiologic and microbiological, and finally with the molecular genetics.
Can I make a comment here, please?
Yes, sir.
I mean, this is essentially for the postgraduate students, those who are present here. We don't see poliomyelitis nowadays, but occasionally we do see polioclastic viruses. And when you have a pure motor illness affecting the lower limbs or something like that, or patchily upper limbs and lower limbs, pure motor, I find that the postgraduate students never think of a polioclastic illness, because to them, polio does not exist in India. But polio does not exist in India. There can be other enteroviruses which can affect the nervous system. So when you have a pure motor illness, acute illness, please keep the low possibility of a polioclastic illness in mind. All right. The second point I'd like to mention is that when we describe the EV70 disease, our initial title of the paper was lumbosacral radiculomyelitis. And then when you read the literature of polio, you will find out that in the beginning phases, you can get sensory symptoms of severe radicular pains. So that does not rule out a polioclastic illness. Those are the 2 points that I'd like to make for the postgraduate students. You know? And the third point that I'd like to make in this chapter, tuberculosis is mentioned only in the columns, tables and whatnot.
Yeah, very true.
There's not a single word written about tuberculosis.
Yeah.
Which is an American perspective, which I accept, which we accept.
Correct.
So when you all are reading this, please keep tubercle very much in mind.
Absolutely. Yeah.
And since Satish put down anterior horn cell polio-like illness, I'd like to reiterate that you do get polioclastic illnesses.
Correct. Absolutely.
Right. I think the point is very well taken that polio is not there doesn't mean that polioclastic illnesses, have also disappeared.
Correct.
Very well taken.
Right. So then in the chapter, there are some very nice tables, like table 4.1 tells us about the global distribution of select microorganisms associated with myelopathy and radiculopathy. And this is very nice to sort of go through. And here we will see poliovirus. It says Afghanistan and Pakistan. Then various types of bacteria, fungi, parasites. So this table is worth reading. It's in 2 parts. Then table 4.2 is microorganisms associated with immunodeficiency. And here, like Dr. Katrak said, which are the cells? I think the immunodeficiencies are classified in the standard manner: cell-mediated dysfunction, neutropenic patients, humoral immune dysfunction, tumor necrosis factor alpha inhibitors being used for various diseases, and barrier disruption like shunts, drains, procedures, lines. Like in our neurosurgical OT, so often we see bugs that are on the skin going into the nervous system. So this table is also, these 2 tables I think are very important from the point of view of the first line in the approach. What does where does the patient come from? Where has he been working? What type of immunodeficiency is there? That will tell you what is likely. So these 2 tables are very informative. Then in the approach, we saw radiology. I have not put radiology because there is a separate lecture on that. And then in microorganism testing, the laboratory testing associated with myelopathy and radiculopathy, you have table 4.4, which tells you for which organism, which test can be done. And as you can see, they are largely now polymerase chain reactions, some serological tests looking at the IgG and IgM. And this table also, I think, is quite useful. This goes about the specific test for each organism. And it continues for the fungi and the parasites. Then we come to table 4.5 on assays targeting multiple microorganisms. And I think this is where the world is moving. The ability for the new generation sequencing to test multiple polymorphisms is increased such that you can test for the all known organisms in one go. And there you have got these various panels which are lined out here. Example in local setting is say pyrosequencing, where you can look at some of the sequencing methods. So I think it is moving to bulk testing, or rather it has moved to bulk testing of evidences of various organisms in one go, so that rapidly you can come to the conclusion, because rapidity is very important in spinal cord. So that was about the testing. Then in the approach,
Satish, what
yes,
is the sensitivity of these?
each one different, sir, and false positivity rate reasonably
Particularly
high.
because of the CSF.
Yes, false positive rate is there because the bug was there, it has gone, or some gene of the bug is being coded. So there are issues with false positivity, false negativity, positive predictive value, negative predictive value, and each one is slightly different.
No, I'd like to reiterate the since you're talking of the PCR, the gene expert.
Yes.
You know, for the sake of the postgraduate students, the sensitivity of the gene expert in the CSF is at best about 40%. Therefore, if it comes out positive, it rules in tubercle. But if it is negative, it does not rule out. So please bear that in mind. And secondly, when you look at table 4.1, sorry, it's 4.2, I think. Yeah, cell-mediated dysfunction. In the Western world, the biggest complication of HIV is cryptococcal meningitis. Whereas in India, it will be tubercle meningitis. Tubercle meningitis with cryptococcal meningitis would be a very close differential diagnosis. So you can see that even the geographic variations are very evident in all these things. So you have to put in your experience and your area into proper perspective. Okay? Use this chapter and these tables as a template and put in your addition, experiences.
Absolutely. Yeah. Right. So in the approach, when you see a patient with isolated myelitis, you mean direct infection and inflammation together. And you will have herpes viruses of various types. And just to make a note that VZV myelitis can occur without a skin rash, though I have never seen an example of this, because probably our serology is not that strong yet, though it is better now with VZV. Then HIV is one which produces a chronic vacuolar myopathy, where inflammation is minimum. So vacuolar myelopathy of HIV is an example where the direct invasion is more than the inflammation. Then recently, a lot of talk about SARS-CoV-2. We still don't know whether direct, indirect, para, or post. Then mycoplasma immune mediated, and Treponema pallidum, meningovascular syphilis, which is believed to cause meningomyelitis, and tabes dorsalis, which presently is rare. Actually, there are so many stories within stories in medicine, and each one makes you think. I mean, where has syphilis gone? Where has syphilis gone? Why have the Treponema not learned the resistance? Why are they still sensitive to ampicillin and penicillin? But I think even when I was doing my residency, there would be cases of tabes dorsalis and meningovascular syphilis. We still see, but only once in a while. So the epidemiology is also very, very interesting. Why has it become less? Now, one point in the box below, the CSF PCR positivity reduces with time. So that's the point that Ashok made, that if the patient comes early and you can send the CSF early, your chances of picking up are highest. And you should always do the serum and the CSF immunoglobulin levels to know for the intrathecal formation of that immunoglobulin. The second set is myeloradiculitis, where in this slide you will see tuberculosis number 1. Syphilis is there, but I don't know where to put it. I have put it immediately after tuberculosis, but in practice, probably now it comes a little lower down. Then brucellosis, not to forget, and deafness is an example. I think how geography matters, one example came to my mind. In one of the summer schools for Indian Academy of Neurology, an interesting case of myeloradiculopathy was being shown, and the patient also had deafness. In a flash, a boy got up and said brucellosis. So subsequently, after the class was over, I asked him, where do you work? He said, Jammu. So in Jammu, that is the commonest myeloradiculitis. And if you have a worker working in Middle East who has come back to India with deafness and myeloradiculitis, this becomes a strong differential diagnosis. So again, driving home the point, where you live, what is your work, what is your immune status, tells you which is likely.
Why is it common in Jammu?
So I have not looked at that.
They don't pasteurize the milks?
I have not looked at that, sir. Maybe I'll do some
I think
homework.
you should have asked that boy, If it's the most common,
yes, yes,
they have the milk directly.
yes. Also in Bombay, I have seen it in once or twice in people returning from Middle East in this classic setting, worker in Middle East and working with the cattle and then coming back.
And I think in Lyme, you should put down bilateral facial.
Bifacial weakness. Yeah. But
just brucellosis weakness, with Lyme, it may be bilateral,
bifacial weakness.
Asymmetrical
Yeah.
weakness.
And skin lesions at some stage.
Yeah.
But I have never seen a patient.
There have been a few case reports in the annals of the Indian Academy of Neurology, more from the Northeast and Bhutan. But otherwise, in our subcontinent, I don't think western and southern areas of India we've not seen.
Then schistosomiasis, the parasite schistosomiasis, I think it's common in some parts of the world, producing insidious lumbosacral meningomyelitis. And apparently this is a common diagnosis in some parts of Korea and some parts of Malaysia. And then of course, fungal in a given setting. So within myelitis, just to say that there will be poliomyelitis, meaning predominant gray matter involvement. Poliovirus, then rabies still comes in India. Other enteroviruses, adenoviruses, and a variety of flaviviruses. And in leukomyelitis, meaning predominantly the tracts being affected, you see the lateral column predominant, which is HTLV. Again, what is the current status of HTLV in India? I'm not too sure, but I think there are very few patients whom antibody is positive. Jimmy, any comments on that?
Yeah, Jimmy should comment.
Jimmy, current status of HTLV1? Jimmy? He's probably not. Then lateral and dorsal column involvement, which is HIV in, again, Tabes dorsalis. I mean, just like Tabes and meningovascular syphilis has become uncommon, I think tubercular spinal arachnoiditis has also become uncommon.
True.
That's another very peculiar epidemiological fact. And sometimes you wonder whether the diagnostic methodology, like the dyes that we use, oil-based dyes that we use, had something to do with it.
To be very frank, I think there's a greater awareness about tuberculosis. And most of the cases of tubercular spinal meningitis have been secondary to chronic intracranial partially treated meningitis, tubercle meningitis. You know, primarily involving the spinal cord to begin with is, I think, a rarity nowadays.
Correct. So there's some epidemiological paradigm shift in this disease also.
Yeah. So,
Yeah.
because I think when we worked in JJ hospital, we saw a lot of it.
At any given time, 3 or 4 patients will be there in the ward.
We saw a lot of it.
Yes.
But now even working in private hospitals, tubercle meningitis is a rarity.
Yes.
Primary,
Coming to us. Yes.
you know.
Yes.
Therefore, I think that is the epidemiology of
Whole disease.
not that. It is, I think, the socio-economic status of the patient,
It's possible.
which is determining, public hospitals, they are there. In JJ hospital, I'm very sure tubercle meningitis is there.
Yes.
But at Bombay hospital or Jaslok hospital, it's not there.
There.
So I think it's a socio-economic strata which determines this.
Right. Then there is a table in the chapter which is about ring enhancing lesions in the spinal cord. And again, like Dr. Katrak has been mentioning, the order needs to be changed in India. I think we will have tuberculosis and cysticercosis, and then everything else. Some of the spinal cord infections lead to spinal cord infarctions, like we said in the beginning, tuberculosis, meningovascular syphilis, varicella zoster virus, and the aspergillus fungus, where the infarctions can be hemorrhagic. Again, I have never seen an example of hemorrhagic spinal cord infarct. But if you see an infarct in addition to a spinal cord syndrome, in a spinal cord syndrome, these are the possibilities.
I think those patients of aspergillus are so ill from the central nervous system. I don't think we ever
We can even pick up.
this.
But cerebral hemorrhagic infarcts I have seen. Yeah.
But perhaps it's shown at autopsy.
Yes.
When the patient has died from aspergillus infarct, diffuse infarction in the brain.
Then I think very briefly the chapter deals with extramedullary infections, where briefly deal with tuberculosis, which will be very, very common here. All forms, vertebral, disc, cord, roots in various proportions, cold abscesses. Then bacterial disc infections and epidural abscess in people who have had trauma or are low on immunity. And dural disease and arachnoiditis, again TB and syphilis here, followed by fungal and sometimes cysticercosis. But cysticercosis in India is more small ring enhancing lesions than meningeal lesions and meningitis or myelitis. Now, in treatment principles, I think achieving early diagnosis perhaps is very, very important here, as much as everywhere else or more, because the spinal cord being a tight structure, the damage is done very quickly and the recovery is very slowly. So I think in that sense, these blanket panels are of help to try and come to a point. And interaction with the ID specialist is very, very important, because I think with neurology, you can come down to the anatomy, you can come down up to a point to the etiology. But these people have their own thoughts about this. Then knowledge of sensitivity spectra in our local setting. There is still a lack of specific antiviral therapies, and you end up giving a blanket treatment when you know that whether it will work or not is questionable. And the last point again is for discussion: role of immunosuppressants like methylprednisolone or immunoboosters like intravenous immunoglobulins. I think we all appreciate that every infection has an inflammatory cascade. Spinal cord has a potential of producing tremendous loss of quality of life. So this, of course, the strategy has to be individualized and case-based. but one would slightly be a little more open towards use of these agents in these conditions, I would think. But again, it's open to questions. So I think we will have comments on this after I conclude on the last slide. So to conclude, clinical features like travel, trauma, exposure, and immune status are very important pointers to the potential pathogen. Recognition of clinical and clinical radiological syndromes can narrow down the differential diagnosis. Direct invasion and immune response are components of the syndrome in various proportions. While specific antibacterial agents are available, antivirals are still lacking, and a case-based decision to use immunosuppressants has to be kept in mind. So maybe we can invite comments on this bit about corticosteroids, injectable corticosteroids, and intravenous immunoglobulin in cases of myelitis, particularly in our setting where we don't always get the pathogen. Any comments on that?
Excellent. Really excellent, Satish. Very, very nicely put and extremely, I mean, summarized it very well.
I like the way you took the tables and worked on them. That's amazing. I like that.
Right. So we go to the next one. That is Darshan.
Sorry, just one comment.
Yes, sir.
Very brief comment. Immunosuppressants, I would just make a comment that steroids are now the standard of care to be given in cases of tubercle meningitis.
Yes.
Whether it is meningitis, spinal meningitis, you have to give for the first 6 weeks steroids. So it's not something that is contraindicated or will flare up the infection. Right?
Even bacterial meningitis, the recommendation is that if a young child comes and you suspect H. influenzae to reduce the ear damage, you give 1 shot of dexamethasone in the casualty only before you do a CSF. So I think we are that way moving towards being a little more open about steroids in infectious diseases in general.
Fine. Let's
Sir, so one comment wanted to make, sir. Good morning, sir.
Rakesh, good morning.
Yeah, very nice talk. Enjoyed, sir. Sir,
you can put your video on also, Rakesh.
Yes, sir.
Let
Yes,
us
sir.
have a look at your face also.
Sir, it's early morning time, sir. For me. Anyway, sir, I just wanted to make a small comment.
Yes.
That when we see a patient of, subacute myelitis, because of the advent of this MOG and NMO, by default, the thought goes more towards demyelination rather than thinking that this could also be a case of a infectious cause.
Correct.
And, because the CSF can also show a lymphocytic response in patients of demyelination, the diagnosis of infectious myelitis sometimes becomes a little more difficult,
And our challenge has always been the bacteriology.
Yes, sir.
So
difficult
our thoughts don't go that way because so at the back of the mind, we know that we may or may not find.
We're not fine, yes.
Rakesh, also the systemic symptoms may make you help you differentiate between MOG and NMO versus infection.
True, sir, but sir, many cases of NMO can be triggered by a short duration of fever also, like 4 or 5 days fever, and you end up getting a subacute myelitis. So that sometimes becomes difficult unless we have, as sir said, a full panel. If we run, we can pick it up.
I think clinically, you should look out for any lower motor neuron signs associated with the upper motor neuron signs. Because as Dr. Khadilkar put up in one slide, polioclastic will have anterior horn cell involvement.
Yeah.
And myeloleukodystrophy lateral columns, which involves all these demyelinating, will be pure upper motor neuron. So just be a little careful about reflexes, etc.
True, sir.
You know,
True, sir.
so if you have an asymmetry of the knee jerk, follow that up a little bit. All right.
Yes, sir.
That's how. Otherwise, what you say is very true, because our mind gets just totally drawn towards smog and NMO and that
Yes.
spectrum disorders. There also the location may help also, you know. The location of the demyelination in MOG tends to be more lower down in the spinal cord, whereas NMO tends to be cervicodorsal area.
Yeah.
Yes. Yes.
The immune myelopathies are coming now. So
Yeah.
thanks, Rakesh. Yeah.
Thank you, sir.
So we request Darshan to start his presentation. Darshan?
Good morning, sir.
Yeah.
Are you able to see the slide, sir?
Yes. So put it on the slideshow mode, please.
Yes. Good morning, teachers. Today I'll be presenting on myelitis and autoimmune myelopathies. Myelitis is inflammation of the spinal cord, and myelopathy is any neurological disorder localized to the spinal cord. The length of the lesion can be very useful. Commonly in MS, it is less than 3, and in NMO, is more than 3 lesions are involved. Differential diagnosis is very broad. We'll look into details afterwards. Epidemiology wise, females are more common. It can affect all ages. In children, ADEM is common and 50% is MOG positive in ADEM. And enterovirus associated flaccid myelitis outbreaks are common in children. In elderly, paraneoplastic myelopathies, particularly associated with breast and lung carcinoma, are common. Dural AV fistula with males and thoracic myelopathy is quite common. Time to nadir, that is on time from onset to maximum neurological deficit. It helps in evaluation and differential diagnosis. If it is hyperacute, that is less than 12 hours, then mostly it's a vascular pathology, infarction in 80%. Acute or subacute, that is 1 to 21 days, then it can be idiopathic or immune mediated. Chronic progressive beyond 21 days, it can be spondyloelectric, dural AV fistula, metabolic, paraneoplastic, neoplastic, or primary progressive illness. So if it is acute, then it can be infarct or trauma. If it is subacute, there's MS, NMO, MOG. We'll look into details afterwards. Sarcoidosis, SLE, Sjogren, paraneoplastic. In chronic progressive vascular like dural AV fistula or AV malformation, inflammatory like progressive solitary sclerosis or primary progressive multiple sclerosis, sarcoidosis, infectious like syphilis, TB, HTLV, HIV, or neoplasm like glioma or metastasis, hereditary like HSP or adrenomyeloneuropathy, or metabolic toxic etiologies like B12 deficiency or toxic myelopathies. So the presenting features are development of sensory motor deficits in one or more extremities, ascending numbness often accompanied by sensory level. It is quite characteristic, and autonomic dysfunction with neurologic bladder, commonly urinary retention, neurologic bowel, and sexual dysfunction is quite common. Demyelinating etiology, 3 characteristic phenomena, particularly Lermit phenomena, Uthoff phenomena, and tonic spasms, which is quite frequent in NMOSD. There are recurrent short-lived episodes of involuntary painful flexor contractions and lasting for 30 seconds to a few minutes. In examination, there's usually a sensory level UMN pattern of weakness. It may take some time to develop. In MS myelitis, particular sign, that is McArdle sign, rapidly reversible pyramidal weakness induced by neck flexion can be seen. And in acute syndromes, presenting feature can be of a spinal shock condition. So demyelinating diseases, MS, NMO, MOG, ADEM, we'll look into that. Neuroimaging, MRI with or without contrast is modality of choice. If it is contraindicated, then CT myelography. In acute or hyperacute, diffusion weighted plus ADC drop is usually ordered. And if there is persistent enhancement beyond 3 months, then there is strong consideration for non-inflammatory, particularly neoplastic dural AV fistula. We'll look into MS myelitis. Usually there is a short lesion. It's a wedge-shaped on axial images, and particularly in the periphery of the cord and in the lateral or dorsal columns. In acute phase, there can be spinal cord edema, and the enhancement can be homogeneous or patchy. and ring enhancement is seen in 1/3 patients. True LETM is a red flag in MS myelitis. In NMO, it is an isolated LETM, extends over 3 or more segments, and it is the most common cause for both the recurrent LETM and monophasic LETM. And bright spotty lesions similar to CSF can be seen. And the lesions are symmetrical, central, involve the gray matter with extensive cord edema. Short lesions in NMO can be seen in 15%. Key points in NMO that it can coexist with other autoimmune disorders, SLE, EPLA, Sjogren's. But if then NMO comes out positive, it confirms that a coexisting autoimmune neurological disorders are there rather than a neurological manifestation of a systemic connective tissue disorder. In the MOG, also there's a frequent LETM. Often it is multifocal rather than solitary. Conus involvement is quite characteristic. On axial lesions are central, restricted to gray matter. So what we call H sign in 30% of the cases, and a sagittal T2 hyperintense line can be seen. Recurrent LETM is rare in MOG, and GADO enhancement is less frequent. As the time passes by, in MS, the lesion, the hyperintensity, it is mildly reduced, whereas in NMO, it is markedly reduced, and in NMO, in MOG, the lesion resolves almost completely. This is a summary of that. MS, it's peripheral, dorsal, or lateral column lesions. In NMO, there is central gray plus white matter, spotty sign, and in MOG, the H sign and conus involvement. The optic neuritis in comparison, MS, there is less than 50% of the nerve, and usually middle, posterior part of the nerve is affected. In NMO, there is predilection for optic chiasma and more than 50% involvement. And in MOG, there is bilateral anterior, more than 50% of both the optic nerves are usually affected. These are the characteristic brain lesions in MS, like in the dorsal pons or inferior temporal, here multiple ovoid lesions. In this area postrema lesion in NMO, there is bilateral middle cerebellar peduncle lesions in MOG, while thalamic lesions, enhancing vessels in MOG. ADEM is primarily in children, usually a monophasic course, and there is a preceding infection or vaccination in about 2/3 of cases within prior 4 weeks of onset of symptoms. Myelitis, usually thoracic cord is most common, and there is homogeneous enhancement. GFAP, it is subacute or insidious onset, often progressing beyond 21 days. Isolated myelitis is rare. It is almost always cerebral involvement is universal. And ovarian teratomas are associated with that. Here there is a characteristic linear or radial perivascular pattern of white matter enhancement in that GFAP associated, and LEPTM with central cord enhancement can be seen. Looking into systemic disorders, sarcoidosis, SLE, Sjogren's, IgG4, EPLA, Behçet's are causes that can lead to immune myelopathies. Paraneoplastic emphysizing and CRMP5 antibodies, and in infectious mycoplasma, hepatitis C, COVID virus also can lead to that. Looking into sarcoidosis, there is a linear dorsal subpyramidal enhancement extending inward from the posterior aspect of the cord and spanning over multiple segments. Longitudinally extensive lesion, but when this dorsal enhancement is also associated with the central canal enhancement, then what we call trident sign is seen in axial images. But despite LETM, the deficit is quite mild in sarcoid. In paraneoplastic, also tract specific lesions, particularly in the lateral columns, more so than the dorsal columns. And
your voice keeps fading off.
Are you able to hear, sir?
Yeah, I'm able to hear now, but sometimes your voice keeps fading off.
Okay, sir. Yes. In 50% cases of paraneoplastic, MRI spine can be normal. So to compare, in the sarcoidosis, there's a trident sign, central lesions. In paraneoplastic, tract specific dorsal or lateral column can be involved. IgG4, there can be myelopathy due to inflammatory pseudotumors, and if it is untreated, then there is extensive fibrosis. Histopathological features like dense lymphoplasmacytic infiltrates, storiform fibrosis, and obliterative phlebitis are the characteristic features of IgG4. SLE myelitis is in 1 to 2% within first 5 years. It is usually LETM. In severe cases, extend even into the medulla. Thoracic cord is most common. If high titers of ANA, anti-DS DNA, EPLA, or low complements are there, then it's a high risk. And recurrence is quite common in SLE myelitis, 50% within 1 year. And in Sjogren's, if it is associated with anti-Rho SSA, then there is a recurrent myelitis risk, and frequently cervical cord is involved. Idiopathic transverse myelitis is a diagnosis of exclusion. The diagnostic criteria, there's a sensory level, it's evolving over 4 hours to 21 days. There is evidence of inflammation and other alternate etiologies are ruled out, then we can label it as idiopathic. The mimics of inflammatory myelopathies can be dural fistula, vitamin B12 deficiency, intramedullary metastasis. In dural fistula, central lesion, flow voids can be seen. In B12 and copper, tract-specific lesions, metastasis as a rim and flame or dot sign, we'll see. Spondylosis also, there's a pancake-like enhancement, central owl eye pattern. And in an infarct also, there's a diffusion restriction and owl eye pattern can be there. So talking about dural fistula, there's a central lesion, here missing peace sign. In amongst the enhancement, there is some part that is not enhancing. The missing peace sign is characteristic of dural fistula. And flow voids, dorsal to the cord, are particularly common. B12 deficiency, tract-specific dorsal or lateral column. Here, dorsal column lesions are, and here the lesion hyperintensity from C2 to C4 is seen. In the metastasis, there's a central lesion. Here you can see there is a post-contrast rim of enhancement around a less enhancing center with a flame pattern above and below of the lesion. That is quite characteristic of metastasis. And in the spondylosis, that can be short or long hyperintensity. It can be like a pancake-like enhancement, that is width and height is equal. And in the axial, there is characteristic enhancement of white matter sparing the gray matter. It's quite characteristic. And the lesions, there is slow resolution of enhancement post-surgery. The infarct, also there's a diffusion restriction, there is a linear strip. The owl eye pattern can be seen, owl eye or snake eye pattern, as there is involvement of anterior aspect of the cord with anterior horns. So looking at labs, aquaporin 4 and MOG should be tested in patients with transverse myelitis in whom clinical and preclinical findings are not suggestive of MS. Aquaporin 4 is positive in 50% of monophasic LETM and 90% of recurrent LETM. Whereas MOG is positive in 20 to 30% of NMO spectrum disorders, which are negative for aquaporin 4. But for NMO and MOG, both serum yields the optimal sensitivity more so than the CSF, and cell-based assays are more reliable. Continuing regarding antibody, if there is low positive MOG and there is low suspicion of the clinical scenarios of MS, then it can be considered, it is most likely a false positive result. And with aquaporin 4, false positives are quite extremely rare. And if there is detection of aquaporin 4, it predicts substantial risk of relapse, more than 90%. It warrants lifelong therapy. Repeat aquaporin 4 is not useful generally. Repeat MOG predicts the risk of recurrence. If there is transient seropositivity, it's monophasic. If it is recurrent, then the disease is quite resistant. And NMO and MOG coexistence is quite rare and 0.06%. And in paraneoplastic, amphiphysine and anti-CRMP5, common antibodies. CSF, WBC count, oligoconal band, IgG index. In MS, cells are usually less than 50. 80% of MS have OCBs or IgG index elevated. In NMO and MOG, cells are quite wide from 0 to 1000. Lymphocytic predominance is common in all. And in oligoconal bonds are less than 30% of NMO cases, present in less than 30%, and in less than 10% of MOG. So to manage, we first have to reasonably exclude alternate etiologies, and we should start high dose IV corticosteroids with 1 gram once daily for 5 days, and treatment should not be withheld while waiting for the results of antibody testing. And patients with myelitis with severe deficit despite steroids, PLEX should be considered. And in MOG, IVIG in acute settings can be associated with good success, and steroid tapering dose can be given. Chronic therapy, MS, disease-modifying therapies, and NMOSD, rituximab, long-term therapy, azathioprine or MMF can be used, or newer drugs like eculizumab, certolizumab can be tried. And in MOG-associated disease, empiric mycophenolate, azathioprine, intermittent IVIG can be effective, or rituximab. So these are a heterogeneous group of disorders. Immune-mediated mechanism and potential for response to immunotherapy is there. Usually subacute in onset. These are maybe monophasic initially, but or the initial manifestation of a relapsing disorder, like in MS or NM. Ancillary testing, particularly MRI, serological antibody markers, and CSF analysis, can help determine a specific diagnosis and correct treatment approach and assist with prognosis. Thank you.
Thank you, Darshan. So, if you can stop sharing your slides,
Yes.
yeah, and we open it for discussion. Ashok.
You know, when that Kazuo Fujihara took a talk on MOG, I remember him saying that the preferential site of the lesion in MOG was lower down in the spinal cord. But in this table 3.2 on page 70, they put out the typical spinal location is cervical or thoracic.
Yeah, I think, sir, the MOG spectrum seems to be expanding a lot. Like Dr. Varsha had 2 patients that were so atypical. So I think the spectrum seems to be expanding quite a lot.
Yeah, but when they put down typical
Yeah.
spinal location,
It started with a lumbar cord.
cervical or thoracic, cervical or thoracic, cervical or thoracic. So all the demyelinating lesions are cervical or thoracic, typical locations. But I was under the impression and taking Kazuo Fujihara's talk, and he's worked a lot on MOG. He had mentioned that if you get a lesion in the lower down in the spinal cord, in the lumbar, consider MOG. But here I find
cervical.
Cervical or thoracic. I just wanted to put it up for discussion.
Yes.
I mean, let us ask Sunila, no, if she's there.
Yeah. Sunila, are you there?
Yeah, she's there.
Yes, she's there. Sunila, what is your firstly, thanks for joining the symposium.
Yes, sir. Yes, sir.
Yeah. And your opinion on where do you see MOG, cervicodorsal or lower
Sir,
down?
actually, initially we would not suspect only. Now that since in the last few years when we have the awareness of this entity has increased, so we have started suspecting MOG. Am I audible, sir?
Yes.
So in these few cases where it has been proven, we have, first of all, we have seen the classical LETM, and it is seen more in the dorsal region, sir. And we have also seen multiple lesions, like multiple elongated lesions.
Okay.
So,
and
another,
cerebral.
yes, sir. And another characteristic finding which I saw in a couple of cases was more involvement of the central gray matter, which Darshan has already touched upon, and even my resident is going to show. In fact, we have had a case of Varsha's, in whom there was this very characteristic involvement of the anterior horn cells of the spinal cord, and it turned out to be MOG.
Okay.
Yes, sir.
In this table on page 70,
yes, sir,
other features in MOG that they have put down is conus.
Yes. So involvement of the conus is also very characteristic, sir. Like if we are seeing an LETM and it is extending up to the conus, then one should first suspect MOG rather than NMO.
So even in your dorsal region,
yes, sir,
upper dorsal or lower dorsal?
More lower dorsal, sir.
Okay, fine.
More lower dorsal.
So then my impression was more or less right, you know.
Yes, sir.
If you go lower down in the spinal cord, consider MOG much more than NMO spectrum.
Yes, sir.
Thanks.
Fine, thank you.
Yeah,
Thanks,
welcome, sir. Yes.
Any other questions, comments on? I think this topic will again come back in radiology, so maybe we could.
Yes, sir. In fact, Darshan has covered quite a bit. So, anyway, it's good to re-emphasize.
Yes. Great. So we move to the third presentation now. Azad. Yeah. Neoplastic myelopathy.
Yes. Yes, sir. So Ashutosh will be presenting neoplastic myelopathies for us. Something we don't see so commonly, but not so uncommon also. So Ashutosh.
Yes, sir. Good morning, everyone. Is my screen visible?
Contradictory statement, Azad, which we don't see so often, but also not uncommon.
Yes, sir.
So which of the two?
So I don't see it very often, but I think others do.
To be very frank, I have not seen it very often.
Okay.
And I think amongst the people, I think I must have had the maximum experience. Oft thought of by the postgraduate students, but very rarely proven. If you take it as a paraneoplastic, neoplastic myelopathies we will be seeing quite often. Okay. Ashutosh,
Yes.
please start.
So this talk is more on neoplastic myelopathies, primaries and metastasis.
Fine, fine.
Good morning, everyone. So spinal cord tumors represent only 2 to 4% of all the primary central nervous system tumors. Shortlisting the probable diagnosis depends on the area of cord involved. So it may be intramedullary, intradural extramedullary, and extradural extramedullary. Out of all the spinal cord tumors, metastases form the major component, accounting for 96 to 98%, and only 2 to 4% are primary tumors. The most common spinal tumor in adults is meningioma, which accounts for 38.8%, followed by nerve sheath tumors, which account for 20.5%. Ependymomas are the most common primary intramedullary spinal tumors in adults. Among children, the intramedullary is the most common. Ependymomas being most common in children, followed by nerve sheath tumors, neuroepithelial tumors, astrocytomas, oligodendrogliomas, glioblastomas, meningeal tumors, and pilocytic astrocytomas. To primary spinal clinically, histologically, and genetically cranial counterparts in several. For example, back radicular or asymmetric and without motor involvement is the most leading the diagnosis of an intramedullary neoplasm. There are some general patterns seen. Astrocytomas are more common, while ependymomas are more central. Spinal show no association between increased grade of malignancy and patient age at diagnosis. And majority of intracranial low-grade astrocytomas harbor IDH1 and 2 mutations, which is rarely seen in spinal cord. So this table shows shows classification of various primary spinal cord tumors, which are divided as intramedullary, astrocytomas, oligodendrogliomas, atypical tumors, mixed glial tumors, mesenchymal tumors, and hemopathic tumors. They are divided into intradural, extramedullary, extra-brain tumors that disseminate to the spinal canal. So here we will discuss mostly the common primary spinal tumors and metastasis. Moving to ependymomas, they arise from ependymal cells lining the ventricular system of the brain and the central canal of the spinal cord. It is the most common intramedullary primary tumor. Clinical presentation may vary from acute onset increased intracranial pressure causing nausea and vomiting to a more chronic and insidious clinical course. So this is a newer molecular classification of the ependymomas, where there are 3 types of spinal subtypes. First of all, the subependymoma and mixopapillary ependymoma, which are WHO grade 1, that is benign, and grade 2, grade 3 anaplastic or cellular ependymomas. So radiological features of ependymoma, they are usually well-demarcated iso-intense lesions that enhance with gadolinium. They may also have a cyst and a syrinx, and hemorrhage may be seen. Some may have a rim of extreme hypointensity called hemosiderin cap sign, which is visible on T2 and S tabuli sequences. So high-grade ependymomas, that is the cellular ones, are usually present in cervical and thoracic region, while mixopapillary ependymoma are usually found in conus medullaris. and the subependymoma, which are rare in spine, cervical region. So this sagittal image shows enhancement in the cervical region with a cystic development in the patient of ependymoma. Ependymomas, which are usually encapsulated, are more amenable to resection. So they must be distinguished from astrocytomas, as the astrocytomas cannot be totally resected. And adjuvant radiation therapy for incompletely resected tumors and long-term surveillance of the neuraxis is important. Coming to astrocytomas, they are intramedullary usually, and they are about 7% of all the primary spinal cord tumors. They're most commonly seen in pediatric population. Most are low grade, but their location and infiltrative behavior precludes the effective resection. They're often lateralized to one side, and patients may have local pain or a Brown-Sequard syndrome. On MRI, they reveal a hypointense T1 weighted and hyperintense T2 weighted lesion with a heterogeneous pattern of contrast enhancement. Usually, the low-grade astrocytomas do not enhance with gadolinium, in contrast to high-grade glial neoplasms, which strongly enhance with gadolinium. So here we can see classic asymmetric involvement in this axial T2 image, where the right side is involved more than the left. Coming to high-grade gliomas, they are WHO grade 4, and they account for only 7.5% of all the intramedullary spinal gliomas. The mean age at diagnosis is usually 39 years and is more common in males. The prognosis of these tumors can be predicted by genetic profiling. For example, newly detected gene mutation in H3K27M has a median survival of around 48.5 months. TRT promoter mutations have a median survival of 77 months, TP53 of 11.5 months, and PPM1D of 84 months. So this image shows a young patient with H3K27 mutation. There is expansion of the right medullary region with thoracic metastasis. Although making the diagnosis through biopsy is hazardous because of location, it is important to attempt definitive diagnosis. For most symptomatic and incompletely resected primary spinal cord tumors, radiation therapy of 5040 to 5400 centigrade, depending on the grade of the tumor, is recommended. So newer modality, which is called proton therapy, which uses proton beams instead of conventional X-ray or electron, is assuming a larger role in radiation oncologic management. Primary central nervous system lymphoma usually arise from large B cells. Only 2% of these are found in spinal cord, rest in the brain. So people who are patients who are immunocompetent have a median age of around 32, and immunocompromised are relatively younger.
Your voice is not coming, doctor. Your voice is not coming clearly.
Hello.
Your voice is unclear. Hello.
Hello. Am I audible
your
now?
Voice much better now. Yeah.
Okay, sir. So patients who are immunocompetent have a median age of 62 years. Progressive myelopathy and radiculopathy are the most common presentations. Often it raises the differential diagnosis of immune-mediated myelopathy syndromes like NMO spectrum disorders. Here, an elderly patient, this is the MRI of an elderly patient. It shows diffuse homogeneous enhancement in the thoracic cord in lymphoma. Coming to meningiomas, they are the most common primary spinal cord neoplasm in adults, accounting for 1/4 of all the primary spinal cord tumors. They are usually benign, that is WHO grade 1. 80% of them are female. 80% of them occur in the thoracic region. In males, it is equally distributed in the cervical and the thoracic cord. And genetic predisposition like neurofibromatosis 2 and prior radiation are some of the risk factors. On T1 weighted MRI images, the tumor are usually isointense to hypointense and exhibit an intense solid homogeneous enhancement. And there may also be an accompanying mural tail. And 98% of these tumors are intramural, extramedullary, and 6% are extramural. So here we can see a cervical meningioma with a tail sign which is extending cranially and is enhancing homogeneously. So the patients with asymptomatic meningiomas can be followed with serial MRIs. Surgery is the primary modality and can be curative. Radiosurgery is used for incomplete resection or recurrence, gaining a larger role in treatment of spinal cord meningioma. And nerve sheath tumors, that is schwannomas and neurofibromas. And these are usually associated with genetic syndromes like NF1, NF2, schwannomatosis, von Hippel-Lindau syndrome, as mentioned in the table. And majority of these are benign WHO grade 1. So here we can see contrast, extradural contrast enhancement, mainly in the cervical region, and two lesions can be seen in the thoracic lesion as well. So a newly described term, which is called stem cell tourism, that is a growing practice among the patients to pay large sums of money to private clinics for often unproven stem cell therapies. So one of the case reported by Berkowitz and colleagues, where a patient developed back pain, paraplegia, and urinary incontinence after receiving intrathecal stem cells for the treatment of deficits related to ischemic stroke. So this is the MRI of the patient, which shows diffuse lumbar intramedullary tumor. On neuropathologic review, it was shown to be a highly cellular proliferative primitive tumor with glial differentiation. There were two other such cases. In one where a boy with ataxia telangiectasia was treated with intracerebellar and intrathecal injection of human.
Again, your voice is not heard.
Hello. Hello. So now am I audible?
Yes, Ashutosh, better.
Hello. Better, sir?
Yeah.
Hello. Yeah. Okay, sir. So in another case, a boy with ataxia telangiectasia was treated with intracerebellar and intrathecal injection of human fetal neural stem cells, who subsequently developed multifocal brain glioneuronal neoplasms. In another case of lupus nephritis, they injected autologous stem cells directly into the kidney, and he subsequently developed angiomyeloproliferative lesions. So this should represent a cautionary tale about such unproven treatments. Coming to spinal cord metastases, which are the most common spinal tumors. So they are frequently extradural, followed by leptomeningeal, and lastly, the intermedullary compartment. Majority of these spinal tumors come from lung, breast, prostate, thyroid, and renal cell cancers. There may also be leptomeningeal dissemination from adenocarcinoma of breast, lung carcinoma, NHLs, melanoma, and gastrointestinal tumors. So treatment goal of metastasis include pain relief, preservation of neurologic function, and maintenance of spinal stability and improvement in quality of life while avoiding the toxic consequences of radiation and chemotherapy. For selected patients, surgical management can be done and conventional laminectomy is usually done. However, coming to newer surgical techniques, which include the separation surgery, which consists of dissecting the anterior sulcus in the spinal canal from the posterior edge of the vertebral body without affecting the vertebral body. This is usually followed by spinal stereotactic radiosurgery, where high-dose radiation ablates the remaining vertebral segment of the tumor, and vertebroblasty is then done to stabilize the bone. So some of the non-neoplastic spinal cord mimics. So since cord biopsy is often hazardous undertaking, recognition of processes that do not warrant invasive procedures is a valuable contribution to patient care. So as Dr. Darshan described, cervical spondylosis usually shows a pancake-like enhancement, and which can persist for months to years after spinal cord compression. Other demyelinating diseases like NMO spectrum disorder, MOG antibody disorder can also produce longitudinally extensive lesions, which can enhance the sometimes enhancing spinal cord abnormalities. So here we can see circumferential enhancement of the cervical spinal cord. The enhancement usually occurs beneath the side of maximum compression. Demographic features suggestive of paraneoplastic myelopathies include those with the NMO spectrum phenotype should be recognized. This has been reported in adenocarcinoma of lung and breast. So older patients presenting with NMO spectrum disorder, particularly if they are male, should be investigated for a neoplasm. Related myelopathy has also emerged recently in setting of newer immune checkpoint inhibitors, for example, nivolumab, which is used for treatment of various malignancies. So, neurosarcoidosis can also produce leptomeningeal and intramedullary spinal cord pathology that can mimic plastic processes radiographically. Here we can see cord expansion and edema neoplasm. Infections with Mycobacterium tuberculosis, Toxoplasma gondii, Schistosoma, cytomegalovirus, and West Nile fever can sometimes extensive and sometimes enhancing lesions. Numerous toxic and metabolic states that subset poisoning can also produce cord swelling seen on imaging without gadolinium enhancement. Tarlow cysts, which are large arachnoid cysts, lesion usually in lumbosacral area, can produce radicular symptoms and thus should be evaluated for possible surgical intervention. So here we can see a Tarlow cyst as at the S2 vertebra. So to conclude, early recognition of signs and symptoms of spinal cord tumors lead to expeditious neuroimaging that can define the compartment and focus the differential diagnosis with excellent accuracy among different histologies. Surgery is usually the primary first-line treatment for symptomatic tumors. Newer techniques, including separation surgery and stereotactic radiosurgery, offer better chances of quality of life in the patients with metastasis. And experience with chemotherapy for recurrent spinal cord tumors is limited, although successes with intracranial counterparts of similar histology may suggest potentially helpful agents. Thank you.
Thank you, Ashutosh. I think the paper is open for discussion. I've got one question for you, Ashutosh. Are you there, Ashutosh?
Yes, sir.
Yeah. See,
Yes.
basically, more and more tumors, spinal cord, brain, everywhere, are having genetic association. So, has the cascade been worked out for some of them? Has the genetic cascade been worked out for some of them? What does the gene actually do? How does it correlate with the tumor? In any of the spinal cord tumors that has been worked out? I mean, we always say that if a particular
yes,
gene is present, the prognosis is good or prognosis is.
Yeah.
How does the gene do that?
Yes, sir. So, sir, some of the genes, like recently, one of the gene described was H3K27M mutation, which usually produces high-grade midline gliomas. But about the mechanisms, I'm not really aware of.
Right. Azad, you want to make your comments on the presentation before we... Actually, I forgot to ask you before we opened it. Sorry.
No, sir, no special comments. Just presented whatever was there in the continuum plus whatever extra we tried to find out from articles in local articles, etc.
Yeah.
Can I say something?
Yes, please, Sunil.
Sir, in his slide on spinal melangiomas, I think it should have been spinal meningiomas, not spinal cord meningiomas.
Correct.
Because meningiomas are intradural extramedullary lesions.
Correct.
So that was like just
yeah.
I wanted to clarify. Yes.
Yeah. Ashok. Ashok, you're on mute.
That's a very good point she raised, because people, when they talk in exam, they don't really explain what exactly they're not in command of the words that they use when they. You know what they're saying is correct, but they're using the wrong words for it. So it's a very good point that Dr. Surya Taki.
You know, as a rule of thumb, we used to say that a female patient dorsal cord will be meningioma. Male patient cervical cord will be neurofibroma. I think from this presentation also he mentioned similar statistics.
I
Yes.
think he was talking more from a clinical point of view, sir, cord,
Correct.
like a myelopathy. But when it comes to anatomy, then that can be an issue.
Correct. Correct. Absolutely.
Yes, sir.
Yeah. Right. So we move on to the next presentation. Thank you, Ashutosh. Lovely presentation. Very clear.
Thank you, sir.
So what is the next one?
Vidhi, sir, my
Next
student.
is, yeah, Sunila. So welcome again.
Yes.
And Vidhi, do put up your slides.
Sir, am I audible to you?
Yes.
Sir, can everybody see my screen?
Yes,
Yes,
we can.
they can see your screen, but they can't see you.
Okay. So, very good morning to all of you.
You go on
my-
this thing, na?
Yes, ma'am.
Go to the slideshow, Vidhi.
Yes, ma'am.
And put on the video, please.
Yes.
It's always good to see a face. That is.
Yes. Can everybody see my screen?
Yes, but just go to the slideshow, Vidhi.
Yes, ma'am. Ma'am, the slideshow is on.
No, the presenting, I mean, it's not the full screen, no? You're still in the...
No, ma'am, I have started the slideshow only. Ma'am, some lag is there over because I have put the slideshow only.
Right side bottom.
Okay. You know that cup sign will be there at the bottom. Just click on
Bottom
that.
on the right side. Yeah.
I can see the full screen only, ma'am.
Okay, fine. Carry on.
Okay.
No, it's not on full screen.
Yes, Vidhi, it is not on full screen.
So three.
The bottom right, you see the...
Yeah, three after what you're done. Three after what you've done. You have clicked one, two after that. Three after that.
You see right bottom where you see
Yes,
the 96%, the icon to the left of the 96%.
Can everybody see the slideshow now? Because on my screen, I can see the
It's not
slideshow.
moved. It's not moved there.
Hmm.
Okay, it doesn't matter. I think this is clear enough. Okay.
So, a very good morning to all of you. My name is Dr. Vedi Rathod. I'm a second year radiology resident at Bombay Hospital. The topic for today is imaging of the spinal cord. So, we'll see the modalities in spinal imaging. MRI is a gold standard and first line imaging modality for suspected non-traumatic myelopathy. Follow-up of non-traumatic myelopathy.
Vidhi, your slide is not changed. We can see it now. Yes.
Yes. Can you see it now?
Yeah.
Okay. We'll
But a part of the slide is getting cut.
Okay. So MRI is the first line for suspected non-traumatic myelopathies and follow-up of non-traumatic myelopathies. It is also the first line for acute traumatic myelopathy for pre-operative planning. MRA with contrast is important for vascular myelopathies. CT on the other hand, as we know, is the gold standard for acute trauma and to know the calcification or ossification of a compressive region. Then we have other modalities like conventional myelographies and post-myelography CT, that is for differentiating arachnoid cysts, arachnoideps, and spinal cord herniation. Then we have conventional angiography, which is important to know about the dural AV fistula sites. And PET-CT has a limited role in spinal region. So we'll start with the compartmental approach to myelopathy. We have three compartments: extradural, second is intradural but extramedullary, and the third is the intramedullary compartment. Grossly, what we are going to see is extrinsic and intrinsic diseases. Extrinsic diseases are divided into extradural and intradural extramedullary, each of which is further divided into neoplastic and non-neoplastic. We are going to see all of these in brief. Intrinsic are also divided into
Excuse me,
neoplastic and
Vidhi, the
non-neoplastic.
slide has
Yes.
not moved.
Yes, ma'am. I'll just see what happens.
See, because you are not on full screen,
Full screen, yeah, that's a
you
problem,
will
I
have
think.
to
So.
just click on the slide on the
Sir, I
left.
have clicked, but still it is not coming as slideshow. I have clicked multiple times, sir. I'm just trying to figure it
Do
out.
you want to just close it and open it again?
Yes, ma'am. Sure, ma'am.
Just close the PPT
Yes, ma'am.
and then again share it.
Yes, ma'am.
Share it again.
Yes. Can everybody see it now?
Yeah, it's just like before, but it's not going to the slideshow.
Ma'am, I'm trying to click the slideshow button, but it is not coming as the full screen.
Hmm. Yeah, but just move your slides. Just go back one or two slides so we'll know whether it is moving at least.
Ma'am, is it moving now?
No, no.
Ma'am, is it seen now?
Yeah, so it is like we can see your slide number 5, but
Yes, ma'am.
I'm seeing part of the slide is getting cut from the top. And if you try to move your slides up and down, I don't think we can see that. Can anybody suggest something that she can do? Sir, Darshan, anybody can help
It's a
in?
Macintosh, no? I'm not too familiar with the
No,
Macintosh.
sir,
No?
it's a Dell. You are presenting from your laptop, no, Vidhi? Dell,
Yes,
no?
ma'am. Yes, ma'am.
There's something
no,
on
no.
top of a
No.
PPT which says product activation failed. I don't know if that is the cause of being unable to.
No, sir.
Yes, yeah.
No, what, when you shared, which screen
Yes,
did
ma'am.
you share? I mean, you first open it on your computer.
Yes, sir. I have opened it on my computer.
And then
After
you
that,
shared.
yes, sir. Yes.
Then it should come.
Mhm.
Anyone from the housekeeping can help?
Support group, anybody?
If you move the slides from the left panel, are they moving?
I'm actually moving on slides only, but I think they are not visible to you all.
Press the left panel, go to slide 4, click on slide 4.
I'm trying. Yes, sir.
Is it visible, sir?
No, it's as
It's
before.
yeah,
as
just
before.
as before and on slide number 5.
Click on slide 4 on the left. On the left. Yeah, that way it is changing.
Go
We
to
can see
slide
slide
3.
4 now.
Go to slide 3.
Is it visible, sir?
You see from the left panel, click slide 3. So you keep clicking the left panel and we are able to see the slide that you have clicked.
So
Right.
can I start?
Right. Yes.
So sorry for all this, sir. So we'll start with the extradural compartment.
Vidhi,
Yes, sir.
your arrow, you keep your pointer on the arrow at the bottom.
Yes, sir.
Okay.
Yes, sir.
And then whenever you want to change the slide, you just click on your pad.
Yes, sir.
Get the arrow down to the lower arrow. Your left hand column where your
Yes, sir.
slides are there.
Yes, sir. Oh, okay, sir.
Put it on the arrow there.
Yes, sir.
Bottom.
Okay, sir.
And now every time you want to change the slide, you just click.
Okay, sir.
No, it won't go like that. It won't go like that. Each slide will have to be clicked.
Yes, sir.
Go ahead, whichever way. Yeah.
Yes, sir. So the first compartment is the extradural compartment. The most common entity is disc herniation. It is the most common mass in the epidural space. Location is the ventral or ventrolateral epidural space. The key anatomy to know whether it is actually a disc or some other mass is that there should be anatomic continuity with parent disc and presence of vacuum phenomenon. So vacuum phenomenon is classical of degenerative disc disease, wherein presence of air locules, which is classically nitrogen, indicates that it is a degenerative disc, not some other mass. Also, the herniated disc will have the same signal as the parent disc, but when the herniation is acute or subacute, the herniated disc might not have the same signal characteristics. Less commonly, herniation can occur in two different compartments. One is the lateral or the dorsal epidural space, where it is important to know because it is frequently misdiagnosed as epidural hematoma. And the second is the intradural compartment. All disc herniations show some degree of peripheral enhancement as well. So as I talk about dorsal disc herniation, here we can see that the disc has herniated and it has come to lie dorsally in the posterior part of the thecal sac, compressing the thecal sac to the right. Here we can see the herniated disc in the dorsal compartment, which is showing some degree of peripheral enhancement. The third is the herniation of the disc in the intradural compartment, which is classically described as a hawk beak sign. So, because for the disc to herniate intradurally, it has to come across the annulus fibrosus and the dura as well. And when the disc comes into the intradural compartment, it resembles the beak of a hawk. That's why it's called as a hawk beak sign, which can be seen on this image. Second entity is a synovial cyst, also known as facet joint cyst. So it is most commonly in the lumbar spine where facetal arthropathy is very common, particularly at L4-5 levels. The clues are that the synovial cyst will have anatomic continuity with the adjacent facet joint associated with arthropathy of the facets, increased buildup of fluid within the joint space, and it will be, the synovial cyst will be directed anteromedially to compress the lateral recess. Since it is a cyst, it will have fluid intensity or some complex internal signal may also be present. And characteristically, these synovial cysts have a thick T2 hypointense rim, which characteristically enhances on post-contrast images. So this is a synovial cyst, T2 hyperintense, T1 hypointense. Associated facetal arthropathy is also seen. As I said, they have a thin peripheral T2 hypointense rim, which characteristically enhances on post-contrast T1 weighted images. The third entity is extradural hematoma and abscesses. For that, there needs to be a history of trauma, spinal surgery, or anticoagulation. The signal characteristics can be variable, and associated adjacent inflammatory changes on MRI can be seen. Abscess on stir appears hyperintense, and there is peripheral post-contrast enhancement with central fluid-like contents. Here we can see that on T2 it appears hyperintense. On post-contrast images, it peripherally enhances with central hypointense components. Next entity is ossification of the posterior longitudinal ligament. It is most common in the C spine, and up to 1/4 cases of cervical myelopathy are due to PLL. On CT, we see fluid ossifications along the course of the posterior longitudinal ligament, which is ventral to the cord. Since its ossification, it appears hyperintense on T1 and T2, blooms on GRE, which is intensely hypointense and gradient echo images with no post-contrast enhancement. OPLL causes significant cord compression, but minimal or absent T2 hyperintensity since it is a chronic entity. And OPLL can also be seen in association with DISH, diffuse interstitial skeletal hyperostosis, which is seen ventral to the vertebrae. This is a sagittal series showing flowing ossifications across the course of the posterior longitudinal ligament. Actually, it is described as inverted T morphology with bud based posteriorly and a thin stalk anteriorly. Then we have cervical and thoracic spondylotic myelopathy. In that, we have narrowing of the spinal canal, which can be ventrally, dorsally, or both. That can be due to developmentally narrow canal, spondylolisthesis, herniation of the disc, osteophytes, OPLL, ligamentum flavum hypertrophy, or ossification and associated facetal arthropathies. The T2 hyperintensity due to such spondylotic myelopathy is often longitudinal, fiddle-shaped, and mildly expansile. A signal abnormality can have reversible or irreversible causes. If it is a faint and indistinct T2 hyperintense signal, it is due to reversible edema. Whereas if the signal is intense and well-defined, it is most likely to be due to gliosis or cystic necrotic changes. On post-contrast images, we might see a pancake-like band of cord enhancement. And the enhancement is often peripheral and limited to the white matter, which often persists even after decompressive surgeries. To lumbar spinal stenosis. Lumbar spinal stenosis has multifactorial causes, which we just saw in the prior slide. And additionally, in the lumbar spine, there can be epidural lipomatosis as well. So in lumbar spinal stenosis, there is focal enhancement of the cauda equina nerve roots at the level of stenosis. And classically, sedimentation sign has been described. So normally, in a relaxed supine patient, the cauda equina nerve roots, they occupy the posterior part of the thecal sac. But when the cauda equina nerve roots, the anatomy is distorted due to any other pathology, the cauda equina nerve roots, they lie in the anterior compartment as well. So they don't sediment as freely in the posterior compartment. So that is a positive sedimentation sign. And this absent nerve root sedimentation is actually, it correlates very properly with the clinical presentation, and that might require further treatment as well. So there are certain grades of classification for lumbar canal stenosis. There is grade 0 to grade 3. Grade 0 is when there's no stenosis, no effacement of the anterior thecal sac. Grade 1 when there's mild effacement of the anterior thecal sac, mild stenosis. Grade 2 is moderate, and grade 3 is severe stenosis, clumping of the nerve roots. Coming to Hirayama's disease, it is also called as monomelic amyotrophy, seen in young males. It is basically non-progressive juvenile spinal muscular atrophy of the distal upper limbs, affecting most commonly nerve roots from C5 to T1. So the pathophysiology is basically that the posterior dura, it shifts forward, especially on flexion. That leads to compression of the spinal cord and causes anterior dorsal hyperintensity. So on neutral images and flexion images, so flexion MRI is the gold standard. On neutral images, we might see some level of cord atrophy from C5 to T1 level. We may or may not see the T2 hyperintensity at that level, but it is better demonstrated on flexion images wherein there is forward shift of the posterior dura causing a hyperintensity at the level of the dura laxity, and that leads to epidural venous plexus enlargement as well, which enhances on post-contrast imaging, which gives a characteristic owl eye, snake's eye, or fried egg appearance. This kind of appearance is not only seen in Hirayamas, it is also seen in ischemic myelopathy, spondylosis, and also in OPLL. Then the next compartment is the intradural, but the extramedullary compartment. There can be myelopathic causes which cause widening of the subarachnoid space. They are mostly benign. If enhancing, they are either meningiomas, nerve sheath tumors, or they can be METs as well. Meningiomas are mostly common in the thoracic spine. On imaging, they appear hypointense on T2 due to cellularity or calcification, and they show intense post-contrast enhancement with the dural tail sign. If the meningioma are multiple, it is associated with neurofibromatosis. Second is the nerve sheath tumor. Nerve sheath tumors are well circumscribed. The most common being schwannomas. Schwannomas are more common. They have a dumbbell-shaped morphology, showing that they have an intrathecal component and a paravertebral component as well, which gets constructed at the level of the neural foramen, giving the characteristic dumbbell-shaped morphology. Multiple schwannomas are seen in neurofibromatosis too, and they have a higher propensity for cystic changes or hemorrhage changes. Neurofibromas. Neurofibromas have a characteristic target sign. Target sign is a lesion which is hypointense centrally and hyperintense peripherally. Multiple neurofibromas are seen in F1. If you see isolated, incidental, small enhancing nodule of the cauda equina nerve roots, it is classically a neurofibroma, and malignant neurofibromas are rare. Myxopapillary ependymomas. Myxopapillary ependymomas are the most common neoplasms in the region of conus or phylum terminale. Actually, myxopapillary ependymomas are intramedullary, but in this journal they have mentioned it as extramedullary and intradural compartment. They are basically a slow-growing variant of ependymomas. They have a characteristic sausage shape. The T2 hyperintense, they have avid post-contrast enhancement because they are very vascular. They can be heterogeneous due to blood products as well. And because of the vascularity, sometimes superficial siderosis or SAH may also occur. The differential is paraganglioma. What is meningeal, metastatic, and infectious inflammatory diseases? So METs basically cause enhancing nodular and non-uniform thickening of the cord, the cauda, and the dura. And the extensive nodular coating of the pial surface is classically described as Zuckergus or sugar coating appearance. There can be infectious, inflammatory, or toxic causes, but that leads to smooth and diffuse enhancement and not nodular enhancement. But specific diagnosis always requires a CSF analysis. Then we have non-neoplastic intradural extramedullary diseases of the dura and arachnoid. In that, the first is arachnoiditis. So arachnoiditis is basically irritation of the arachnoid that causes post-inflammatory adhesions that can be idiopathic, iatrogenic, or traumatic most commonly involving the cauda equina nerve roots. So in that, we have certain grades. This is the normally spaced cauda equina nerve roots. They are spaciously placed. They are not thickened within the thecal sac. In type 1, they are mildly thickened and they are slightly crowded. In type 2, they are almost peripherally placed within the thecal sac, giving the appearance of empty thecal sac sign. In type 3, they are all clumped together centrally. And arachnoiditis ossificans is the most severe form wherein we see calcification. Secondly, coming to arachnoid cysts. They can be located in any compartment, but most commonly they are intradural and extramedullary, mostly located in the thoracic cord dorsally. They are well circumscribed, have imperceptible walls, and they are isointense to the CSF. On heavily T2 images, they are best seen. They can also be seen on myelography. Coming to the third entity, arachnoid webs. They are basically incompletely or disruptedly form arachnoid cysts, most commonly located in the thoracic spine, and they have a characteristic sign, scalpel sign. So this, as we can see at this level, there is acute compression of the thecus sac, which gives the appearance of a scalpel. And this scalpel sign helps differentiate arachnoid webs and idiopathic herniation. One more important point is there, by which we can differentiate both entities. We'll see that in the next slide. So the fourth entity is idiopathic spinal cord herniation. It is actually herniation of the spinal cord into the extradural compartment through defect in the dura, which is most commonly caused due to osteophytes. So the cord displaces ventrally. Most commonly, it is seen in the region of the thoracic spine from T4 to T7 levels. Heavy weighted T2 weighted images or on myelography, you can see that there is ventral displacement of a short segment of the cord, which is covalently kinked. And as a result, there is ventral loss of subarachnoid space and compensatory expansion of the dorsal space. And basically, how can we differentiate idiopathic spinal cord herniation? Is that in idiopathic spinal cord herniation, ventrally we won't be able to see any CSF, whereas in arachnoid web we can see that ventral to the cord we can still see a layer of the CSF. So that's how we can differentiate. Fourth is the intramedullary compartment, which can be either neoplastic or non-neoplastic. Certain features are present through which we can differentiate whether there is a neoplasm or not. Longitudinal extent of the lesion. Usually neoplasms are long segment, expansile, they have a mass-like appearance, and they're associated with hemorrhage, cysts. Usually they have intense post-contrast enhancement and associated findings outside of the spinal cord. So the most common intramedullary neoplasms are ependymomas, astrocytomas, and hemangioblastomas. And then we have METs. So the first is ependymomas. Ependymomas, as we know, they arise from the ependyma. So they have a central location within the cord, most commonly the cervical spinal cord. They are not capsulated, but they are well circumscribed because symmetric expansion of the cord with internal heterogeneity. They are hypointense to isointense on T1, hyperintense on T2 with a characteristic hypointense hemosiderin cap sign, and they show strong post-contrast enhancement. Second is astrocytomas. Astrocytomas are the second most common primary neoplasms in adults. Contrary to ependymomas, they are expansile, but they are eccentrically located and poorly defined. If you see a tumor that is holocord, it is most likely to be an astrocytoma. The enhancement, as we can see, is minimal or absent. Hemorrhage is not common. We know that ependymomas, in the hemorrhage is common, and astrocytomas are associated with NF1. Third is hemangioblastomas. They are the third most common primary cord tumor in adults. They can be sporadic or they can be associated with von Hippel-Lindau syndrome. They are eccentric. They have two components, cystic or partially cystic with an enhancing neural nodule. They are highly vascular, that's why they have two flows and show avid post-contrast enhancement. The thing about hemangioblastomas is that even small lesions produce significant amount of abnormal intramedullary T2 hyperintensity. Fourth is METs. METs are mostly singular and they have characteristically two important signs, the rim and the flame sign. So rim line is when there is an intense rim of post-contrast enhancement, which is peripheral. Flame sign is when we see flame-shaped T2 hyperintensity superior and inferior to the lesion. There is a dot sign which is not that significant, but which is basically a central punctured dot of intense post-contrast enhancement. So rim sign, flame sign, and dot sign, they are very important signs to say that it is METs. METs also cause disproportionate edema. Hemorrhage and cystic changes are not common, and they show avid uptake on FDG CT. Coming to non-neoplastic intramedullary diseases, number one is multiple sclerosis, most commonly seen within the spinal cord. We can remember that it is short segment because it is MS, so there are two letters. So we can remember that it spans less than two segments craniocaudally, classically involving the lateral and dorsal aspects of the cord. If it is enhancement, then we can say that the plaque is active. The enhancement can be ill-defined, it can be solid, ring, or partial ring-like. Then we have longitudinally extensive myelitis. There's a long segment myelopathy. So MS had 2 or less segments, and long segment in longitudinal extensive myelitis, we have 3 or more segment in involvement craniocaudally. In that, we have 3 entities. We have NMO, neurosarcoid, and more IgG associated disorders. So the first is ivaporic IgG seropositive NMO-SD. There is involvement of the cervicomedullary junction most commonly, and there are bright spotty lesions on T2. So bright spotty lesions mean that the lesions have intensity which is similar to CSF. So they are that bright on T2, and they may show a patchy or heterogeneous or ring-like enhancement or partial ring-like enhancement, as we can see in these images. Then the second entity is sarcoidosis. In sarcoidosis, there can be a variety of presentations. There can be leptomeningeal enhancement, which is the most common in 61% of patients. There can be pachymeningeal enhancement, intramedullary lesions, and in few patients, there can be bony involvement as well. Cervical cord is more commonly involved than thoracic segment. Characteristically, sarcoidosis has a proclivity for involving the dorsal or the pial surface of the cord, and if there is enhancement of the central portion of the cord as well, it gives the appearance of a trident. So this characteristic enhancement is known as trident sign. So trident sign is basically dorsal pial surface and central cord. So if all of them enhance, it gives the appearance of a trident. This subpial enhancement can even persist for over 2 months after corticosteroids are given. Then coming to MOG. In MOG, there is T2 hyperintensity, which is confined characteristically to only the gray matter. So that gives the appearance of H. So it is called an H sign. There's preferential involvement of the thoracolumbar region, and the post-contrast enhancement is only minimal. Then coming to viral myelitis or myelopathy. In viral myelitis, the MRI may be normal, or there can be long T2 expansile hyperintensity of the central gray matter, particularly the cervical spinal cord. In viral myelitis, if it is in the acute or early subacute phase, we might even see post-contrast enhancement or enhancement of the nerve roots. There can be hemorrhagic necrosis. If hemorrhagic necrosis is present, then that will lead to heterogeneous signal and T1 hyperintensity. In viral myelitis, there might be thickened and enhancing cauda equina nerve roots. In polio, specifically, as we know, there is selective involvement of the anterior horn cells. And HIV causes vacuolar myelopathy, as sir has already described, that HIV causes loss of the myelin of the nerve fibers, so that creates vacuoles inside the nerve fibers. So characteristically in HIV, and long-standing cases have spinal cord atrophy. Then coming to paraneoplastic myelopathies, commonly associated with lung cancer and breast cancer, we see a long segment of T2 hyperintensity, which is symmetric and tract specific. For example, this patient was a case of breast cancer, and this patient had only selective involvement of the dorsal cord, whereas this patient was a case of lung cancer, and he had specific involvement of only the lateral spinothalamic tracts. So that is present, tract specific enhancement. Coming to toxic metabolic iatrogenic myelopathy, in that number one, we have subacute combined degeneration of the cord, most commonly seen with B12 deficiency. We know that the selective involvements of the dorsal columns that gives a characteristic inverted V or inverted rabbit ears morphology. If there is involvement of the lateral columns as well, that gives rise to a 3-point sign. Characteristically, cervical cord is involved, or upper thoracic cord may be involved. The differentials are copper deficiency, methotrexate and nitrous oxide toxicity, heroin-induced and HIV myelopathy. Then second is radiation-induced myopathy. Radiation-induced myopathy is rare. It is a dose-dependent complication of radiation, can be seen early or early delayed or in the late time frame. On MRI, we see non-specific spindle-shaped or fusiform T2 hyperintensity with or without expansion. And involvement of the lateral and the dorsal spinothalamic tracts is characteristic. Chronic radiation can lead to atrophy of the spinal cord with cystic myelomalacia. The ancillary clue to help us will be fatty marrow replacement of the vertebra, which appears as T1 exaggerated hyperintense signal. And radiation-induced myelopathy, also one ancillary clue is that there is enhancement of the cauda equina nerve roots. Coming to the last topic, vascular myelopathy, we have 3 rings. spinal cord infarct, spinal dual AV fistula, and cavernous malformation. So coming to spinal cord infarct, number one, it commonly affects the thoracic cord and conus. Typically, most commonly affected artery is the anterior spinal artery distribution. As we can see, MRI may be normal or it can show restricted diffusion of the cord with corresponding ADC drop. In spinal cord infarct, this preferential involvement of gray matter, which is known as H-shaped or butterfly-shaped appearance or owl's eye or snake's eye sign. Less commonly, the posterior spinal artery is affected. In hyperacute phase of the infarct, we might see T2 signal hyperintensity, which is described as being pencil-like on SAG images. And in acute stages, we might see cord enlargement and some enhancement. And caudal nerve roots might also be enhancing when there is spinal cord infarct. And 1 to 2 weeks after the spinal cord infarct, we might see vertebral body infarcts as well. Second is spinal dual AV fistulas. It is the most common type of spinal cord vascular malformation. In spinal dural AV fistula, we see on the posterior pile surface increased serpentine vascularity, which is seen as prominent to flow voids along the dorsal cord surface, and these flow voids show post-contrast enhancement, characteristically seen on heavily T2 weighted images. Now, this fistula also leads to venous hypertension, which causes expansile cord T2 hyperintensity. And in the cord, when there is extensive T2 hyperintensity, one part of it might not enhance. So one geographic piece which is not enhancing is known as the missing piece morphology, described in spinal dural AV fistula. This missing piece is actually normal because the venous drainage over that area is normal. And the other part, which is T2 hyperintense and enhancing on post-contrast imaging, has actually poor venous drainage, and that leads to enhancement. So MRI with gadolinium bolus technique can be roughly used to know the site of the fistula, but the gold standard will be catheter angiography. Lastly, coming to cavernous malformations. Cavernous malformations are tumors related to repetitive hemorrhage which present as mass lesions. They are low flow vascular lesions, and if the size increases more than 1 centimeter on 2 subsequent scans, we can say that subsequent hemorrhage has occurred to the lesion, and that's why the increase in size. It is basically depending on the blood products. It is varying ages blood products are seen, which leads to popcorn type morphology, and that causes blooming on gradient images. One more thing is that we'll see adjacent hemorrhage in the cord extending craniocaudally away from the lesion. And since it is a cavernous malformation, there will be no post-contrast enhancement. The differentials will be neoplasms which have flow voids, hemangioblastoma or ependymoma, or even post-traumatic contusions. To conclude, MRI is the first line in spinal cord imaging. We have broad differentials of abnormal T2 cord hyperintensity, but we can narrow it down by using a compartment approach to myelopathy. We have specific imaging features, certain signs, ancillary findings, and enhancement features, and multiple modalities apart from MRI, like flexion MRI for Hirayama's disease, CT myelography for arachnoid lesions, and Dura. Thank you.
Thank you. Thank you very much, Vidya. I think it was very exhaustive and very nicely put together. Thank you.
Thank you, sir.
Sunila, you want to make... No. Sunila, you want to make your expert comments before we open it for discussion?
First of all, thank you, Vidhi. Despite the little hiccups in the beginning, I think you spoke very well.
Thank you.
And sir, I basically we want to emphasize, like she put it in her concluding slide, that causes of spinal cord T2 signal abnormality especially are several. So very often we need, in addition to these imaging findings, we need a lot of clinical inputs. So that is how we can narrow down our differentials. Otherwise, findings can be pretty non-specific in several cases.
Correct. Clinico-radiological syndrome.
Yes. So this is one area where clinical inputs are very, very important. I mean, if I just see cord signal and I think it's a myelitis, stroke demyelination, and then someone tells me, no, this patient was fine and he had a fall, then I would think of a spinal cord contusion.
Mm.
That
Okay.
way. the other features of a fracture and all may not be very evident.
Correct.
And myelitis can be very non-specific. So at the time of presentation, I may just see LETM, and whether it is acute transverse viral myelitis, MOG, NMO, they can look very similar.
Right.
Quite often.
Yeah. Great. So let's open it for discussion. I have one question and a comment.
Yes, sir.
I think the question is for all postgraduate students.
Mhm.
There are so many signs that are here. I mean, they just dozens of them. So how does it? How do you look at these signs? How does it help you? What does it help you with? And the second question is, Sunila, do we really know what is the how thick are the correlations of these signs with the diseases? Do we know what percentages they are present? And I mean, it's very nice to talk about them and very nice
Yes.
to name them after animals and
Yes, sir.
eatables and whatever. But
Yes, you are so right, sir. In fact, in this for this presentation, when Vidhi was preparing, actually I came across all these newly described signs like the rim sign and the flame sign, and uh, sir, I mean, every few days somebody is describing a new sign.
there seems to be some fascination
Yes,
about
exactly, sir. I mean, I don't know why, but and there are certain examiners who love to ask these signs,
yeah.
and I think in our day-to-day practice, it's not always very useful.
So that's the perspective that probably. Yeah.
Hmm.
I think there are two people here. I think Dr. Katrak and Dr. Khadilkar who have signs after them.
Oh wow!
Fascination
Sir,
with
My
science.
sir
sign
wanted
is
to make a comment.
non-specific.
Sorry.
It's not my sign.
Yes, it is, sir.
No, Jimmy. I told sir we'll call it Dr. Katrak sign. He refused. So we
Yes.
called it hair loss sign.
No, but
Very
Satish, you
frankly,
facilitated it.
very frankly, it is for others to say, "Okay, it is a sign described by so and so." Now, I think I would reiterate all these signs, and I would digress a little bit to describe so many signs described from Lucknow in myopathies. You know, Satish,
Yes.
like trophies on a wall. I don't know what all. Valley between two hills, but they don't mean anything regarding the etiology. There is no specificity. So I personally feel even in brainstem vascular pathology, I get totally confused what is Foville's sign and what is Weber's sign and what is this sign and that sign. But I can localize my lesion to that.
Yeah.
Then if you tell me there's one which is lateral gaze deviation, okay, with contralateral hemiplegia. The other is, I think, a sixth nerve palsy with contralateral hemiplegia. Now, lateral gaze is in the sixth nerve nucleus. The sixth nerve neurons are in the sixth nerve nucleus. How can you split a hair and make a new sign and what?
Correct.
It is
Correct.
important that these signs localize to the pons.
Correct.
Otherwise, they have no other meaning.
Correct.
Yeah. And very frankly, I'm very poor with names. So I can hardly remember the names of the various signs.
Yeah. I think if allopathic practitioners disallow names, signs to be named after people, half of the signs will disappear.
I mean, it's basically, I think it's an ego trip.
Correct.
the only sign that I would say is relevant in neurology is the Babinski sign.
Yes. Yeah.
You know,
Thumbs
which
up to that.
pain and even Gauer's sign is specific for a myopathy. It's not specific for Duchenne's.
No.
Yeah.
No. In fact, I have a feeling that it gives a slightly wrong impression about the perspective in which the student looks at that particular thing. So I wanted to know from the students, how do they associate these various signs with the way they learn? Anyone?
I think I will give you the answer. If they find out that a particular examiner is fond of science, they will mug up all the science.
Sir,
If Dr. Katrak is an examiner, they won't mug up the science.
sir, I wanted to make comment. Hello.
Yeah.
Yes, sir. Sir, the signs are I think quite. They will basically point to a certain thing, especially when it comes to the spinal cord, because as Dr. Sunila said, there all the lesions look same. These signs do help us, sir. Like in patients of MOG or NMOs. I mean, if you pick up that bright spotty sign and those typical signs which are clearly known, they really help, sir. Sometimes, I mean, they are not very sensitive.
No,
They
we're not
do
saying.
help to a point.
Yeah, no, I think what you're saying is they are pointers.
They're pointers, yes.
But they are not sine qua non. That's what the student has to appreciate.
True, sir. True, sir.
But Rakesh, you have to pick them up, no? You have to pick up the findings.
True,
Only
sir.
then they convert into a sign. But if you don't pick up the findings, how will you pick?
Yes, sir. True, sir.
So I just want to say that so when there are multiple differentials and we see a lot of findings, when we see a characteristic sign, for example, when we see in SACD we have inverted ears sign, then that really reinforces the diagnosis for us if it is clinically correlated as well. Just for surety.
Okay,
Yes.
so inverted the rabbit ear. Now tell me, what does the sign? I mean, just if we have a minute or two, I have got some questions about that sign. What is in between the 2 ears that is still gray? Are we saying, when we are saying inverted V sign is there, are we saying tract of Gall is intact and tract of Barda is affected? What is in between the 2 ears that is still gray? Whereas clinically, you see there are patients in whom lower limbs are affected more than the upper limbs usually. And there's an occasional one in whom upper limbs are affected more than the lower limbs, but they all have the inverted V.
So now, Satish, you must call it inverted mold V sign, unmold V sign. Both the tracks are involved, and it becomes a mold V sign.
Yeah. But sir, tell me, in a B12 deficiency patient, have you ever seen a signal that covers both the tracts and that is just a triangle where everything in between is affected?
I have
It is still
there is something more to that inverted V, which Sunila has to tell us.
Sir, we have had this discussion once earlier also, I remember,
I know
in the
this
classroom.
is at least 10 years I have been struggling with this.
Yes, sir. In fact, I always tell the residents that whenever you are...
anatomical landmark which differentiates between the tract of Gall and Barda in the posterior columns?
Radiologically, you mean?
Yeah. Even anatomically.
I don't think there is.
Anatomically, is there a landmark which divides the two?
So that's the whole point, that there is no anatomical landmark, but there is a radiological landmark. So there is something very different happening there.
So that is why, sir, I always tell the residents that when you're talking about a sign, no, you try to understand what does it mean. Like yesterday, I asked Vidhi, okay, what do you mean by the missing piece sign, which has been newly described in spinal dural AV fistulas? I'm glad. I mean, there seems to be something by means of which we'll be able to differentiate. But then, in this article, nothing was mentioned, but there was a cross reference. Then we went through that cross reference. We read that entire article. Finally, in one line, they had described that what happens is that due to presence of these AV fistulas, there is the venous drainage is hampered, but some part of the cord may remain spared. So there the venous drainage will be normal. So from there the contrast washes out, whereas in the remaining involved cord, it will remain, it's abnormal. So the contrast kind of pools over there. So then I told her, I said, whenever you are describing a sign, you try to understand what is the logic behind it. Only then it is going to be useful.
Correct.
The same with all these syndromes. They help you to localize the lesion. Apart from that, there's hardly any meaning.
Exactly, sir.
I mean, just to make another comment on this, that intellect is about differentiation. Intellect wants to dissect.
Yes.
And therefore, all these dissections exist.
Hmm.
But they may mean a lot or may not mean a lot. Intellect is the whole property of intellect is about dissection.
Okay. And very frankly, I'll add something to that. And wisdom has a tempering influence on the intellectual dissection.
Correct.
Wow.
Absolutely correct. Absolutely
Excellent,
correct.
sir.
Sir, just say it again. Wisdom has a temporary
Tempering effect
Effect.
on this intellectual dissection.
Ah.
Excellent.
Excellent.
Great.
There is, I had sent you or no, Satish?
Yes,
You
it's
and Jimmy.
beautiful.
Okay,
It
there
is
is a
beautiful.
difference
I
between
don't recollect this.
intellect.
Intellect and wisdom.
All those differences. Yeah.
Again, differences.
Sir, wisdom will take long time to, they will take long years before we reach your level. So I think till that these signs will help us and syndromes will help us.
With Rakesh, by now you are not acquiring a certain amount of wisdom. You will not.
Yeah.
You have to start. You have to start.
True, sir.
It's only then will you accumulate.
He is taking refuge in his black hair. Right. So we go to the second last one now. Thank you very much, Sunila and Vidhi.
So,
Thank you,
We
sir.
go to the
you mean to say people who dye their hair have no wisdom?
they're taking refuge
They
in this.
take refuge in their black hair.
Yeah, so vascular myelopathies, again Darshan, because Chandrasekhar had to go, and Junior Rakesh. Rakesh, are you there?
Yes, sir, I'm around.
Yeah, great. So Darshan, you want to start?
May I request all the postgraduate students to get rid of this sir and ma'am in the titles, please.
Yes, sir.
Rakesh Singh has not been knighted by the Queen. With the sir.
Yes.
Okay.
So then that would be Sir Rakesh Singh with a capital S.
Just get rid of this, sir. On the titles, you can put Dr. Rakesh Singh. That's enough.
Yes. Sorry, sir. Yes. Shall I start, sir? Is the slides visible?
Yes, Darshan.
Yes.
Visible and audible.
Yes.
Do go ahead.
Yes. So frequently patients who are initially diagnosed with idiopathic transverse myelitis have alternate etiology, and vascular is most common in them. there is important time to treatment concentration. If there is delay in diagnosis, it is associated with worse outcomes. And some treatment for like steroids in inflammatory disorders can potentially worsen the symptoms in vascular myelopathies. Characteristic features like severe acute deficits within 12 hours of with pain is quite characteristic for vascular. And if there is chronic features associated with exertional and Valsalva maneuver causing worsening, that is also quite characteristic. Talk about approach to acute myelopathy. First, we need to secure that airway, breathing, circulation. We need to rule out trauma, aortic dissection. We need to rule out emergent MRI is fine. We need to do to rule out cord compression or flow voids, blood, or stroke investigations we need to send. So we'll talk about vascular anatomy of the cord. It consists of a single anterior spinal artery and paired posterior spinal arteries. Anterior spinal artery arises from two branches of intracranial V4 segments of vertebral or picas or cervical segmental branches. It is non-continuous in mid-thoracic zone. So there is a watershed area. And posterior spinal arteries, they are also arising from picas or proximal vertebral. The blood supply is not sufficient, so they are reinforced by from upwards to downwards by vertebral arteries, subclavian arteries, posterior intercostal, lumbar, and iliac arteries. Here you can see the reinforcement, and these arteries feed into the spinal branches, divide into anterior and posterior radicular arteries at each segment level. These radicular arteries also only a portion of that provide a significant contribution to the spinal cord. That is anterior and posterior radiculomedullary artery. Rest of the radicular arteries terminate within the nerve root, dura, or pial plexus. The main cervical radiculomedullary artery is at C3, another at C6, C7. That artery of Adamkiewicz, the great anterior radiculomedullary artery, is most often located between T9 and T12. The range is from T5 to L3, but T9 and T12, between that, it is most common. So anterior 2/3 supplied by anterior spinal through central sulcal arteries running from deep to superficial. Posterior spinal artery supplies posterior 1/3, and at the tip of the conus there is an anastomosis between them. Here you can see anterior 2/3 anterior spinal, posterior 1/3 posterior spinal. Venous system is also similar to that from the internal venous plexus. Then from the radiculomedullary vein, it connects the internal vertebral and external vertebral plexus, and it joins the azygous vein and its stomach. So dividing into categories, we'll talk about arterial ischemia, venous congestion ischemia, hematomyelia, and extraparenchymal hemorrhage. Arterial ischemia can be periprocedural, spontaneous infarction, or a spinal cord TIA. Here, as you can see, there's a hyperintense lesion in the center of the cord involving ventral gray matter, and here there is an owl-eye appearance. So periprocedural first was described by Sir Esley Cooper. There was a large traumatic aneurysm of iliac artery, and then it was described first. Most commonly, it is caused by open or endovascular thoracic aneurysm repair, 50% cases. Other surgeries, cardiac, aortic, angiography, nerve blocks, epidural injections can also lead to that. Mostly, majority of the patients, 80% of them wake up from the procedure with maximum deficits, and other develop symptoms over hours or days. Flaccid paraplegia is quite common. In more than 30%, there is less severe deficit. But characteristic is that pain is much less frequent than in spontaneous. In spontaneous, pain is quite prominent, and pain is quite less in periprocedure. So treatment-wise, during the spinal cord ischemia, the goal is to increase the spinal cord perfusion pressure through collaterals. It can be done by two ways: by lowering the pressure within the spinal canal via either the CSF drainage or increasing the MAP, or both. Then regarding spontaneous, so misdiagnosis of spinal cord infarction as transverse myelitis have been found in 15% cases in 2 large studies. It can occur at any ages. Mechanisms in elderly usually associated with vascular risk factors, one in young people with fibrocartilaginous embolism or vertebral dissection. Etiologies can be atherosclerotic, or can be associated with dissection, or can be embolic phenomena or mechanical fibrocartilaginous embolism, or vasculitic phenomena, hypercoagulated state. Drugs like oral contraceptives, sildenafil, abusive drugs can cause. Clinical features either localized to anterior spinal artery commonly, or less frequently posterior spinal artery. Absence of classical pattern like brown sick cord or central cord, it is that absence is also frequent. And severe pain, either back pain, chest pain, neck, or limb at or before onset in 70% of the patient. The faster and more severe the deficit, the easier to diagnose infarction. And usually there's a physical maneuver frequently reported at or before onset. That can be lifting or hyperextension or Valsalva, neck movement, and things like that. So for a diagnosis, the criteria, first there should be an acute non-traumatic myelopathy, and nadir should be, the maximum deficit should be within 12 hours or less. Or if it is not, it is more than 12 hours, then the severe deficits should rapidly develop over 12 hours or less. An MRI should show no spinal cord compression. It should have intramedullary T2 hyperintense spinal cord lesion or supportive like diffusion, ADC restriction, or associated vertebral body infarction or arterial dissection. CSF should be non-inflammatory, and alternative diagnosis is ruled out. So coming to neuroimaging, diffusion weighted ADC should be performed in acute settings, but sensitivity is only 50 to 70%. It takes days to involve, so in initial imaging, it can be normal. And T2 hyperintense signal is typical. It can be like a pencil-like, different lesions and owl-like. In subacute also, there's a variety of patterns. Is diffusion restriction or associated with that vertebral body infarction or arterial dissection. But the red flags are if there are large lesions out of proportion to mild deficit, or signal extending entire length of the cord, or separate well-defined lesions, or a small lesion with severe edema, then the infarction is quite, it's a red flag for that, and it can be a different etiology or a very different presentation. In the chronic setting, it is very difficult to differentiate. Sometimes classical findings like myelomalacia, cord atrophy can be seen, or a residual T2 hyperintensity in a particular vascular territory can be seen. So treatment-wise, it is reasonable to discuss risk and benefits of RTPA within first 4.5 hours of onset if suspicion is high and patient understands the limited evidence. If it is not administered, MAP augmentation with or without lumbar drainage can be done. And if there are atherosclerotic risk factors and stuttering decline, then dual antiplatelets and high-intensity statins can be used. Outcomes are variable, but despite severe deficit, 50% patients usually walk without aid. Spinal cord TIA, there are spells affecting bilateral limbs, vascular risk factors can be there, and they're different from stuttering decline, which is frequently seen in infarction. That is that in that deficit fluctuate but accumulate in the decline, but in here there is transient deficit only. Second is venous ischemia. So spinal durative fistula is most common in that. 70% of spinal levy malformation is spinal durative fistula. It's an arteriovenous shunt composed of connection between a radiculomeningeal artery and a single radicular vein, which will lead to venous hypertension. It will lead to spinal cord congestion and ultimately ischemia. Its incidence is 5 to 10 per million per year. Older population, particularly males, 40 to 80 is a age range. There is frequently history of some back surgery or trauma in many patients. So clinical features: gradually progressive thoracic myelopathy, plus symptoms frequently referable to conus or roots. And most characteristic is dramatic worsening of deficits with either Valsalva or lumbar puncture or some exertion. What are the procedures that lead to venous pressure elevation? Pain is also quite frequent. Sensory level can be there, most frequent in L1. Sometimes 50% patients receiving corticosteroids have significant worsening. It leads to venous hypertension and it can lead to worsening. Sometimes durative can be an incidental finding, rarely. In the neuroimaging, in the hyperintense signal can be seen. It is longitudinally extensive. Frequently, more than around 90% conus can be involved. Flow voids. Here it can be seen. That is due to engorged perimedullary veins. It can be seen on dorsal or ventral surface. Dorsal is more common than ventral. And here that multiple small flow voids are seen here also. And some post-contrast abrupt missing pieces. That enhancement areas are missed because of that contrast arrangement. And it's a missing piece sign. Here it can be seen. And yes. And another characteristic is hazy with central canal prominence. This central canal prominence can also be found in dural levy fistula. DSA is usually gold standard, but non-invasive MR angiospine should initially be considered to localize the fistula before the DSA. Treatment: embolization, where DSA 70 to 80% efficacy, or surgical disconnection of the vein. It is 98%, but embolization, we can avoid the surgery, but failure rates are high. Long-term improvement can be there in 40 to 40% patient, and strongest predictor of outcome is clinical severity before treatment. That is the strongest predictor. Then we'll talk about hematomyelia. It is an intraparenchymal spinal cord hemorrhage. It is quite rare. Trauma is most common cause. Intramedullary spinal cord cavernous malformation and AVM are then the second and third most common cause. Severe back pain at onset followed by rapid severe myelopathy. And you should recognize the blood products within the spinal cord. So the etiologies can be trauma, cavernous malformation, the popcorn appearance is there, arteriovenous malformation, phloids, bleeding tendencies, neoplasms, some spinal cord aneurysm, infections like varicella zoster, HSV, acute hemorrhagic leukoencephalitis, or idiopathic cause. So cavernous malformation is most common etiology of non-traumatic hematomyelia. First is trauma, non-traumatic first is cavernous malformation. They are a cluster of tightly packed dilated sinusoidal veins. It's a cluster of veins with no intervening parenchyma and no feeding artery, no any draining vein. So most cases are spontaneous. Males are more common. Family history in 10%. If the malformation is multiple, then in 50%, there can be a positive family history. Radiation and trauma are quite significant risk factors. If the lesion is more than 1 centimeter, then very high risk of bleeding. Here we can see that classic popcorn appearance. And so treatment, if asymptomatic, then we can observe in patients with progressive deterioration, surgical resection is required. If surgery is done within 3 months of symptom onset, or the size is more than 1 centimeter, or if there are predominantly motor symptoms, then they are favorable factors. Second is arteriovenous malformation. It comprises a direct connection between a feeding artery and veins without an intervening capillary network. It's a connection between artery and vein, but no intervening capillary. When the AV network, that is nidus transition between artery and vein, that is AV malformation. But when there is a direct connection exists without capillary network, that is AV fistula. In 30 to 40% spinal cord aneurysm is associated with AV malformations. So classification was given by Ensign Spetzler in 1992. Dural AV fistula is the most common one. Second is intramedullary glomus malformation. Third is intramedullary juvenile AVMs. Fourth is intradural perimedullary. It can be a simple fistula fed by a single arterial branch, or intermediate size fistula fed by multiple dilated arteries, or a large fed by multiple giant arteries. And fifth is epidural fistula. This is the type 1, most common type, most commonly in the thoracolumbar levels, usually T5 and L3. Second is that glomus one in the anterior half, usually at cervicothoracic junction. There is a tightly packed nidus of dysmorphic arteries and veins in direct communication with the capillary bed. And the juvenile type, here the nidus also has an intervening neural tissue, and it can involve vertebra and paraspinal tissues also. In this perimedullary AV fistulas, yes, 8 to 20% of spinal AVMs, and it is located on the cord and fed directly by artery supplying the cord. So spinal AVMs, the intramedullary phloids can be seen. DSA confirms the presence of AVM. Earlier treatment is recommended. Endovascular embolization is typically preferred because of high risk of intra-op complication. But if it is posterolaterally located, then surgical resection can also be tried. In some cases, stereotactic radiosurgery can also be tried. The differentiating feature between dural AV fistula, spinal cord AVM, and that extra perimedullary AV fistula. Dural AV fistula usually acquired. AV malformation is congenital. Symptom onset is acute in AV malformation. It can be acute medullary syndrome, or in dural AV fistula, it can be chronic progressive myelopathy. And bleed is less common, though it can. Bleed is quite common in AV malformation. Last is extraparenchymal spinal cord hemorrhage. There can be epidural hematoma or subdural or subarachnoid. Epidural is most common. Most common cause is trauma or after surgery, or epidural catheterization or lumbar puncture are other causes. Treatment, if it is symptomatic, then emergent surgery. And if improved outcomes are there, if it is performed within 12 hours of symptom onset. So to conclude, these are the uncommon but frequently under-recognized neurological disorders. High index of clinical suspicion should be there for ruling out possible vascular etiology in patients with myelopathy. And if you provide proper treatment and while avoiding potentially harmful treatment, it will improve outcomes. Thank you.
Thank you, Darshan. Shall we now ask Rakesh for his comments? Rakesh has large experience now in these conditions. Rakesh, you want to make your comments?
Yes. Yes, sir. As Darshan said, spinal dural AV fistula is one of the most common spinal malformation. And though the literature says the improvement is 40 to 50%, in our clinical practice, we find it is really 80 to 90%. Unless the patient is plegic, that is grade 0 power. If the patient, even if he has 1 or 2 grade power, usually they improve really well. Some spasticity and urinary complaints do remain. Second thing wanted to say about the AVM, it's same like brain AVM. If it is a real AVM, that is the nidus is inside the spinal cord, irrespective of the modality we use, the treatment outcome is not good, because ultimately, sir, as you said, we are going to damage the normal spinal cord when we are treating, either by surgery or endovascular means. So a asymptomatic AVM should never be treated. Asymptomatic dual AV fistula, if easy to treat, can be treated. So the clinical observation and the deficit is important in all these malformations, I would say. Yes, sir.
Great. And you have a series of how many patients now? Quite a large series, no?
Yeah. Yes, sir. Now we have nearly 52 patients, sir.
Yeah.
Over last 10 years.
Fantastic. I mean, that's one of the larger.
Yes, sir. But same thing as we are trying to write it also. Ki nearly, practically, I would say 70 to 80% of the dual AV fistulas are diagnosed obviously like a transverse myelitis. Yes. They receive immunoglobulins, plasmapheresis, steroid, and then comes to the diagnosis of. So we should really have a very high index of suspicion when we see a long segment demyelination and patient is not responding.
The one question that I wanted to ask you is, when there is a spinal cord tumor and the tumor expands, then vascular channels become engorged, and around it you see some vascular anomalies. So is it difficult to differentiate the primary from secondary? I mean, a tumor with secondary vascular changes, does it look sometime like a primary vascular malformation? Have you had that instance anytime?
Not in the MRI.
Sorry, hemangiomas and hemangiocytomas means really very vascular tumors. They can sometimes cause confusion. But most of the time, dural AV fistula veins will be outside the spinal cord. So they will be on the surface. And second thing is that all these veins are traveling up and down. So though the fistula will be at the lower level, or say a tumor or edema is at the lower level, we'll see all these veins right from cervical cord to the lumbar cord. Most of the time, I would say 50-60% of the time.
Due to the back
that gives us a better idea here. Yes. But highly vascular tumors, yes, it's a confusing picture. But if we do DSA, it is pretty clear, sir.
Right. Yeah. Ashok has a question.
Some few points. One is, I'm a little frustrated that amongst the MRI machines I deal with, the diffusion of the spinal cord is not a default test. And I don't think it's a default test all over whenever you send for a spinal study, diffusion spine is not a default test. So that has to be brought in. The second is,
yes, sir.
Classical spinal TI. Classical spinal TI is not a diagnosis which is common. To the best of my knowledge, I have not made a single diagnosis of a spinal TI that comes across as the preceding for a spinal infarction. The only possible exception to this would be intermittent claudicatory symptoms of the cauda in backache situation. To differentiate between a pure discopathy with a discopathy along with a vascular impairment. And Dr. Varia was very fond of trying to differentiate one from another on the history. And the third thing is, one of the etiologies of a spinal infarction in the arteria Adamkowitz that I must mention, that I have seen, which is not mentioned in today's presentation, is a spinal infarction following weightlifting. This was a young, extremely tough 22-year-old male who was a trainer to a very well-known film star in Bandra. And he was trying to teach his student, who's himself a very great film star, the art of doing a deadlift. So just to impress him, he put a very large weight and tried to lift it up, and the strain became too much, and then suddenly he collapsed with the weight, and everyone thought that because he found the weight too much, but actually he was paralyzed in the lower limb. And by the time he brought in the hospital, the story was almost over. It took it about 3.5 months for him to be able to stand again. So the weightlifting, and this has been described, we looked it up at that point of time in the literature. Weightlifting as a sudden lifting of weights as a cause of spinal cord infarction has been described. So it's a very interesting sort of thing I thought I'd mention.
You know, in about the spinal cord TIAs,
yeah,
I have seen one young person who was part of a band and was the person who played the bugul. And he, every time he would sort of continue to blow into it very strongly, he would have symptoms in the lower limb, which gradually went on increasing. And then once he just could not stand. But then he sat down for half an hour and he was better again. And that is when an AVM in the dorsal region was diagnosed. So Valsalva maneuver doing something like a TIA. Yeah.
Yes, sir.
Yeah.
It is
Sir,
classically described with a vascular thing, sir.
Sir, one more point is mentioned that the myelitis, because of the dural AV fistulas, will actually worsen after giving solumedrol. So that is also one of the pointer mentioned to differentiate with other causes of myelitis.
I think now with the MRI coming in so quickly, particularly in our setups where MRI is done on the same day, you start getting the leads very quickly. I mean, these descriptions must be of a slightly earlier time when it would take time for the MRI.
Time to diagnose them,
and in the meantime, you have given medication.
No, but you know, Rakesh has pointed something very interesting. You know, I think sometimes it is very difficult on MRI also to differentiate between an infarct, you know, from a dural AVM, AV fistula from a myelitis, you know.
Yeah.
And recently only we had a patient with, you know, who we actually gave the solumedrol, methylprednisolone, and within 3 hours, from a power of 4/5, he went down to 0/5. And of course, then we thought of dural AV fistula because that is, you know, known rarely to cause this, you know, worsening with steroids. And of course, I think Rakesh did the dural, you know, the DSA and didn't really find anything. And then we looked up the literature and there are reports of methylprednisolone actually worsening in patients of, you know, spinal cord related to these vascular causes.
Yeah.
Sir, how is that patient doing now? Because I remember having seen his scans.
Sheila is better. He's better. He's walking, but it's been, you know, it's been now 2 or 3 months. So
Yes, sir.
But he's now, you know, he's beginning to walk.
Sir, have we repeated the angio? Because in those couple of reports, they mentioned that the repeat angio showed the malformation.
Yeah, I think we did it twice. Once the second time, but the second time also was some time back, you know.
Okay.
But I think he's doing well. In this case, I don't think it was a dural AV fistula. But you know, very similar, no? This
Yes, because he worsened with steroids and he had an LETM, no, sir, quite a long segment of involvement.
Yeah, absolutely.
Rakesh, what is the embryological origin of these things? Because you never see anything on the skin or that myotome or dermatome. What is the embryology of these malformations? Or is there gene behind it? Hello? Hello. Hello.
You're audible. You're audible.
Huh. Rakesh, any information on that? The embryology of these malformations? Or maybe worth looking up.
Sir, likely lost the connection. Sir.
Who, Rakesh?
Yes.
Yeah. Okay. Fine. Worth looking up. Yeah. Sir, only the last one is remaining now. So you will be staying on, or you will be?
Stay for about 5-7 minutes.
Yes. So let's go to the last one. I think between Azad and Jimmy, they are presenting, because one presenter's father is not well, so he had to go.
So I just like to make a statement. I'm very grateful to Azad. What happened was actually, Dr. Chandrasekhar was supposed to take this topic, and unfortunately, I think his father fell very sick with a stroke. And then, I asked Varsha. Varsha was supposed to do it, and her grandmother expired. So I think this is a rather, and then of course, Azad very, very kindly at the last minute, has worked this up. So thank you very much, Azad.
Thank you, sir. Thank you. Yes. Yes. Okay. So we'll start with the last topic for the day, that is a cauda equina syndrome. Are my slides moving?
Yes.
Yes. So definition. So cauda equina syndrome basically is defined as a constellation of symptoms and signs that happens due to pressure on the lumbosacral nerve roots of the cauda equina. These would generally include back pain with urinary symptoms, generally retention plus or minus overflow incontinence later, bowel dysfunction, constipation more common than incontinence, sexual dysfunction, saddle anesthesia, and lower extremity pain and weakness. There is no single definition, and that's why often literature is very divided about different things about cauda equina. That is, what are the etiologies, what is the epidemiological prevalence, what are the prognostic markers for surgery. All of it is different purely because different definitions are used. So much so that the article says that totally 17 definitions exist for cauda equina syndrome. However, one thing is certain, that cauda equina syndrome is a neurological emergency. And hence, the rapidly we treat, the better the patient outcomes can be. The name cauda equina comes from the Latin word for the horse of a tail. Basically, cauda equina is the nerve roots below the...
Azad, tail of a horse, not horse of a tail.
Sorry. So it basically is made up of all the spinal nerve rootlets from L2 to L5 and all the sacral and the coccygeal nerves. This area is an area where the cord has already ended. Remember, the cord normally ends at L1 and in rare cases somewhere in the middle of L2 of the vertebral body. So there are no upper motor neurons present here, and hence a pure cauda equina syndrome will not have upper motor neuron signs. If there ever are upper motor neuron signs, clinically we should think that the etiology is affecting the conus as well, or it is multi-level along the neuraxis. What does the cauda equina normally do? It provides sensory innervation to the saddle area, motor innervation to the sphincters, and parasympathetic innervation to the bowel and bladder. Main importance, like we said, it is an emergency. However, out of the multiple people which comes to us with backache, only 4 out of 10,000 they say are going to be cauda equina syndromes. So it is very difficult to see those few important ones out of a whole large load of back pains. So the most important question obviously will remain about involvement of sphincters. For any backache, that probably should be the most important question, even if we are in a busy OPD like a camp. So what are the causes? By far the commonest cause is discogenic, that is a disc which has slipped out and is pressing on the cauda equina. This is supposed to form 40 to, in some case series, even 60 to 65% of the causes. As it is a structural cause, it may be amenable to surgery. What are the other structural causes? So a lumbosacral spinal stenosis, spinal epidural lipomatosis, or any sort of trauma with the fragments pressing on the cauda equina. Next, vascular, a hematoma, an aortic dissection, and a dural AV fistula. They say that the cauda equina is the part of the spinal cord which is used to getting the lowest amount of blood flow, and hence is very easily affected even by small drops in blood pressure. It is said that in a study of post-cardiac arrest patients, at autopsies, the cauda equina had completely necrosed. The cauda equina nerve roots had completely necrosed, further supporting this hypothesis that lack of blood supply first affects this area. Next, neoplastic, multiple causes, inflammatory, multiple causes. Sarcoidosis happens to be the commonest. In neoplastic, this maxillopapillary type is supposed to be the commonest. They say 10% of neoplastic causes of cauda equina are this particular type of tumor, because that is where it grows. Amongst infection, multiple etiologies are known. Just one specific thing that was described is something called an Esperg's syndrome, which again, they say can form up to 10% of the infectious causes of cauda equina syndrome. It is a herpetic reactivation causing radiculitis of the lumbosacral nerve roots, plus or minus myelitis. And further rarer causes include radiation or repeated intrathecal chemotherapies, which can cause arachnoiditis. It is important to note that predisposing factors like obesity or lumbar canal stenosis will make a patient predisposed to getting a cauda equina more easily. So even a smaller disc protrusion in an already obese person may cause the cauda equina more easily. Symptoms and yes, sir.
Just one question at this point. We have seen how many cardiac arrests?
Yes, sir, many. And
have you ever seen a cauda equina following a cardiac arrest?
No. So out of the few who do,
you stressed on the point about it getting very little blood supply.
Yes. Not seen. I agree, sir. I agree. I did think about that. The ones who recover, we've not really seen them.
I did not hear of this entity, cardiac arrest, until I read this chapter.
Okay.
You know, so I'll keep this question open to the house. Has anybody seen cauda equina syndrome following cardiac arrest?
No.
So the only thing I can think of is the fact that I think 90% of patients with cardiac arrest have such a poor prognosis, and they're not
in a good state to even communicate with you. So getting a history of cauda equina is not out of the way.
No. Question is after they recover, you know. This must be after they recover.
Yeah. Those few people who recover, I have not sort of encountered anyone with a cauda equina. Quite right.
Okay. I'm sorry, I'll have to leave now. Thank you.
Thank you.
Right, sir. Thank you. Thank you very much.
Hi, sir.
Yeah.
Okay. So now we go on to the symptoms and clinical findings. I have already discussed the symptoms as a part of the definition. However, let's look at how common each one is. So low back pain or pain in the legs, that is often described as a sciatica type pain, is described in more than 90% of the patients. This pain in the legs is worse in supine or erect position and is relieved by flexing the spine forwards. Urinary symptoms are also seen in more than 85% of patients. In the chronic cases, it may start off with just a decreased sensation and a poor stream, and soon it become a complete retention with overflow incontinence. Bowel dysfunction can be seen in 65%. Why bowels are less involved than the bladder, nobody has yet been able to explain, but it has been seen in multiple studies that bowel involvement is much lesser than the involvement of the urinary sphincter. sexual dysfunction, depending on how proactively we will ask, the range can be from 12 to 96% of patients. This could be erectile dysfunction, ejaculatory impairment, impotence, even priapism has been described, dyspareunia, or urination during intercourse. Saddle anesthesia remains an important finding. Lower extremity weakness. And it is important to note that some patients may not have the entire constellation. And cauda equina, by definition, is often asymmetric, unlike conus, which is symmetric. On clinical examination, like we said, it is a purely lower motor neuron syndrome, hence flaccid lower limbs with absent or sluggish DTRs. The perianal or sometimes the perineal sensations are lost completely, and the sensory loss can even be in the buttocks and the posterior thighs, depending on how diffuse the involvement is. The rectal tone is lost, and the bulbocavernous reflex is also lost. 30% cases are known to be acute in the sense that they don't have any prior history of significant back pain, whereas 70% are considered chronic because they've been having back pain since long and gradually progressive symptoms. So we'll finish the signs and symptoms with this nice mnemonic, horse tail. So easy to mention the symptoms in an exam. Horses, have you had any of these symptoms? A would be the sexual changes, R is the urinary, S is the sciatic, that is the back pains and radiating down the spine, E again erectile dysfunction, T is tone, altered sensation, inability to stop, that is stop the bladder, and leakage. So a few of the things have been covered in this. How do we diagnose cauda equina syndrome? First and foremost, like we said, very rare amongst the whole magnitude of back pain patients that we get, and hence a high index of suspicion is needed. MRI would often be needed urgently if there is any involvement of a bowel and bladder. For those rare patients where MRI is not possible, a CT scan will be done. The commonest etiology, that is disc in half the patients, a contrast scan is not needed. However, if there is no disc visible that is causing the cauda equina syndrome, then contrast will be needed. Other investigations which may be done, especially in chronic patients where they don't really come up with the symptoms of urinary retention, but just say that we have incontinence, a USG with a post-void residue to actually look out for the retention is needed, and urodynamic studies may also aid. This is probably the most classic description of a discogenic cauda equina syndrome. For some cases who are imaging negative, that includes imaging with contrast negative, we may need to do angiographic studies because vascular causes are not uncommon. CSF studies because infection is not uncommon. And lastly, EMG NCV may be needed to confirm this. The EMG NCV shows acute denervation at multiple levels, and it also needling the bilateral external anal sphincter may help. Mimics. Severe diabetic neuropathy can sometimes mimic, as it can have bowel and bladder involvement, and of flaccid lower limb, areflexic. Pudendal neuropathy, but then pudendal neuropathy will not involve the lower limbs. And sometimes even MSA, because of all the we often have MSA patients who are elderly and have other comorbidities leading to a neuropathy. And then in them, when the bowel and bladder is involved, it could be a mimic at times. Prognosis. Prognosis has been difficult. There are multiple studies, but many of them say nothing is really a prognostic marker. Just a few prognostic marker which some studies have supported is the amount of pre-op deficit, more the worst. Bilateral sciatica, worse than unilateral sciatica. And patients with complete perineal anesthesia may have a worse prognosis. That is honestly it about the cauda equina syndrome. We'll just take another 2 slides to differentiate it from conus medullaris syndrome. Like we can see, conus medullaris is the part in red, whereas cauda equina are just the nerve roots. So conus medullaris is the terminal end of the spinal cord, below which protrudes the pia mater as a phylum terminal. The conus ends at L1, and the upper end is normally not well known. So here in conus medullaris syndrome, we will also have upper motor neuron signs, generally from the sacral segments. This is a slide to differentiate the two. Conus levels versus cauda equina level, which is more diffuse. The presentation of conus is always sudden and symmetrical, whereas cauda may be gradual or acute, but very often asymmetrical. The radicular pains are more severe in cauda equina syndrome, whereas the general low back pain is more common in conus medullaris. Motor strength, it is symmetrical and relatively less affected in conus as compared to cauda, where it is more severely lost, the lower limb power. Reflexes in conus, the ankle jerks are absent, knee jerks present, whereas in cauda equina, both knee jerks and ankle jerks are absent. Sensory examination, perineal area symmetric and bilateral, cauda equina saddle area asymmetric, unilateral, and they even say that sometimes there can be something like a sensory dissociation in conus, not in cauda. So that tactile sensations may be present in conus if the whole tract has not been involved, the whole hemisection has not been involved. Sphincters in conus are earlier, cauda equina sphincters are a little later, again in the chronic variety, and sexual symptoms like impotence are more frequent in conus. One extra point to note is prognosis for conus medullaris syndrome is supposed to be more dismal than in cauda equina, where it is anyways not much better. In summary, high index of suspicion, it is a neurological or a neurosurgical emergency. The important question about involvement of bowel and bladder should be asked when there is this large pool of backaches which come to us. Prognosis is generally poor, and hence we need to take care and prevent it. Thank you.
Really excellent. Very sharp presentation. Ashok has a comment.
The most frustrating thing a neurologist will have to do with conus cauda is to see the patient for the first time after the orthopedic surgeon has operated on his lumbar spine. It is a very, very frustrating, time-consuming, and almost always an unsuccessful exercise. When these guys operate, at what level they do, what they do, God only knows. I've had some pretty bad experience from some so-called famous surgeons. I don't know how to go about it.
Yeah.
Have you had this experience, Satish?
Yeah. It's a difficult area in terms of prognosis and recovery. And then often we come on quite late.
They never do well enough. The problem is they never do well enough.
Jimmy, you want to make comments?
No, I think it was an excellent presentation, really nice and comprehensive and short. I think, yeah, but maybe Ashok, maybe the highly unsuccessful surgeries were probably more in the past. Nowadays, with very precise, MRI localizations and, more of, less invasive surgeries, I think that we are seeing, I think, a little less and less of those failed cases, or you don't think so?
Then maybe you and I live in different planets.
Okay. Now, we have seen, disasters also.
I've got one very fundamental question. Is there any point in differentiating conus from cauda? Why are we having these tables everywhere? What are we achieving? What are we achieving by this differentiation?
Bladder. What worries me the most is the bladder.
Well, bladder comes in both.
But the incidence of bladder involvement.
I mean, so much is made out of this conus versus cauda, and questions are asked, and there are tables in textbooks.
It's a very popular question.
Yeah, even our neurology simplified, we have a left side and the right side saying this is more and that is more. And what are we gaining by differentiating cornerstone cauda?
It is a mixture of the two. There is
It's always a mixture of the two.
Yeah.
So
Correct.
why are we separating? Is there any point, or it is just something that is an intellectual exercise that?
No, the only thing might be the localization. If we
How does it change anything? Because the diseases are the same.
Yeah.
MRI involves the whole area.
Correct.
Yeah, that's true.
So I think it's one of those things that have been just like saddle anesthesia. It interests me. I mean, who sits on a horse now? What is saddle anesthesia?
So maybe
we are just going on and on with things that have been traditionally there. Do we need them?
So maybe because the disc can be at multiple levels, so you want to be sure which is the most symptomatic disc. I mean, because L5S1 is so common. I mean, if you get a disc around L1, L2, and both are there, then probably you can tell the surgeon that probably I feel that the upper one is more symptomatic.
So that's your clinical evaluation.
Yes, sir.
Which says that one particular route is more affected, go after it.
Yes.
I mean, I think there is a lot of this sort of thing involved in clinical neurology, which has to change with time. And conus cauda is one of them. Similarly, there are areas like pupillary sparing, brainstem syndrome that were mentioned earlier. I think they have been there. They are part of evolution of neurology. But I don't know how much they...
Probably, sir, because I think because the all the clinical science seems to be waning. So we want to hold on to this conus and cauda and keep asking in the exams before somebody throws it out of the books.
Yeah. I think for students, it is important to know that while it's nice to have a left side and a right side and a tabulated thing, they will coexist. So pure cauda, pure conus won't be that common because pathologies don't know these boundaries now. These diseases don't know these boundaries. These are made by us.
Sir, there is one even epiconus. There is a epiconus syndrome described, which says that the level of lesion is around D12L1. So it will cause basically gastroc weakness with a extensor plantar. I mean, that would specifically localize to D12L1.
Yeah. See, localization wise, this thing will have a value.
Yes.
Etiology wise and management wise, not that.
May not make a difference. True, sir. True. Absolutely.
Great. So I think we've had a very nice continuum today. Ashok, you want to say something? Yeah. We've had a very nice continuum to begin 2022. I think we discussed quite a bit of things. Also, everyone kept his or her time. So that's again. So next we meet, Azad, you want to announce next one? And before Azad announces, please, whoever is attending, please make sure that you fill the forms because the forms are important and Azad has put them on the continuum group. Yes, Azad.
Yes, sir. So tentatively it's 1st May, headache. We'll soon put up which topics we are doing and invite speakers.
Yeah. I think this speaker division, let's do it in the coming week itself so that we have enough time for preparation and enough time for people also to know who's doing what.
Yes.
Any closing remarks, Jimmy, Ashok?
No, I think it was an excellent meeting. Huh? Very informative. And I think everyone spoke extremely well. And I think we've come out with good information.
Yeah. So I think this one student and one mentor thing will continue in 2022. It seems to be going quite well. Right?
Absolutely.
One mentor per student. Rakesh, next time you want to take part?
Yes, sir. Yes, sir. We'll do.
This time the JJ people were not there.
We'll do it, sir, next time.
Right. So whichever. So topic list will float.
Sure.
I'll also involve Dr. Ravi Shankar or Devashish Chaudhary or whoever. Yeah.
Thank you very much, sir.
Great.
Thank you.
Very enlightening.
Sunila, special thanks for being
Yes.
being here today.
Yes, sir. Thank
And
you. It's my pleasure.
Vidhi did such a good job.
Yes.
Thank you, sir. Thank you.
I mean, Jimmy and Ashok, just to say that our radiology department every time
Yes.
attracts very high merited students. For MD in radio, it's MD, MD radiology.
Yes, sir.
Yes, every time they get students who are very good, very interested, high on the rank, and obviously they do very well, which is fantastic.
Fantastic.
Yes. Thank you
Great.
very much.
So,
Okay.
great. So we
Bye.
close at that. We'll
Yes.
see you all on 1st of May. Thank you very much.
Yes. Bye. Bye.